for healthcare associated infections. Many a time this query comes and people have a generalized question, how it is different. They are not different, but the terminologies have been defined in a better version now. So any X disease with what patient came and admitted in a hospital and then developed a Y disease during the time of his duration in the hospital, that is nothing but a hospital healthcare associated infection. Probably, definitely it is acquired in the medical setting during the course of his treatment. And the prevention of such healthcare associated infections lies towards us, the one who are the part of HICC, that is the Hospital Infection Control Committee, and the one who is there in the infection control team. What are these two terminologies? I'll be talking further. Okay, as we know the history of infection control, ये कोई आज की बात तो है नहीं. It's a very old story. It's as old as our mankind. So there have been people who have worked for this infection control practices to how to eradicate or how to eliminate or to minimize the infections which might be prevalent during those eras also. So yes, we know about the name of Semmelweis, Louis Pasteur, Joseph Lister, Robert Koch, Florence Nightingale. In their times, they definitely worked and definitely emphasized on eliminating or eradicating the infections. So as we are talking about, aaj ka lecture is all about what is hospital infection control, what comprises of infection control, what are the prerequisites which is required to formulate an infection control committee, who all should be there, what are the different parameters, what is surveillance, how we calculate the surveillance indicators, what are the main indicators which are required for infection control practices. My whole lecture of 1.5 to 2 hours will be related to that only. So when we talk about hospital infection control, HIC, अगर इसकी बात करें, इसके 3 components हैं. So when we first is the infection control program. This is a program, it is operating at 2 levels. One is an executive body and the other one is an advisory body. Executive body से नाम से आप समझ सकते हैं कि not more than a formulation of 4 to 5 people are there who works on day-to-day basis. An advisory body, yes, there will be team of people who will be working here, who will be formulating a advisory group जहाँ पे हर बंदे की हर input की हमारे को ज़रूरत है और उस ज़रूरत को how to be formulate further to improve the practices, to improve the standards of our institute. So that comprises of the Hospital Infection Control Committee, जिसको हम HICC भी कहते हैं. So this is all about the program. Infection control program, as I said, एक होता है infection control committee बनाना, then is the infection control team, and lastly we need to have a jotted, a systemized manner, a standard operating procedures, what we need to follow on day-to-day practices, why the HICC, why the infection control team. So that comprises of nothing but our infection control manual. To start with, what is HICC? Infection Control Committee, एक कमिटी बनी हुई है पूरी की पूरी. बहुत बार ये मुझसे सवाल पूछा जाता है, मैम, what formulates the infection control committee? Everybody needs to focus on this. Yes, 3 or 4 people cannot actually arrange all the elimination program or the practices which are to be improved in the hospital system can be taken up. There has to be a list of people, people who are accountable for things. They are all supposed to be a part of Hospital Infection Control Committee. To start with, we need to have hospital administrator as the chairperson. This is also a query very frequently. People, I think, who are addressing HICC committees probably know the challenge here, what we face. Why hospital administrator? Why not somebody else? So the answer to this is, in a hospital system, if the higher hierarchy people are there, the administrator is involved. So definitely the nth person can go and definitely ask for their problems. They can look into the matter. Very financial issues are there. There are administrative issues are there. So whom do we address it? So hospital administrator or the chairperson of the Hospital Infection Control Committee can be the one. In my case, in my hospital, our medical superintendent is the hospital administrator and the chairperson for Infection Control Committee. Because yes, I as a member secretary, I address the problems there, and then it can be taken up to the higher board of directors, to the management, that yes, these are the problems, these are the challenges we are facing, and here is the financial constraint. We require to have such instruments with us, we require to change the disinfectants, we require to have the proper cleaning practices. So the accountability lies to this person, whether it is at the administrative role, whether it is at the financial role. So chairperson to this committee can be any person in the hospital administration, likely either to be a medical super. If it's a medical college, it can be a medical superintendent or the principal of the institute. If it's a standalone hospital or it is a small nursing home, then the director of that hospital can be the hospital administrator or the chairperson for hospital infection control committee. Then the second most important person comes the member secretary. इसमें भी बहुत बड़ी सवाल पूछा जाता है कि why member secretary has to be somebody from the laboratory side. So the answer to this is member secretary has to be either the in charge or the head of the unit of microbiology. Because why? Member secretary will be the second in command person who can actually address the administrator. What are the problems facing? What are the organisms which are being prevalent in the institute, in the hospital setup? Then thirdly, what are the different antimicrobial variants which is coming, where the challenge is coming, what problems we are facing, whether it's a multi-drug resistant organisms, which bugs which are entertaining us, or there is any liability of things which are not. Sir, I think the glitch is coming somewhere. Still, people are saying it is not audible. Kindly check your site. So we are talking about the member secretary. Member secretary will be definitely the in charge of microbiology, who can look into the organisms which are prevalent in the system, and secondly about the antimicrobials, whether it's a multi-drug resistance, whether it is any challenge in the MIC values of the drugs which is causing, what are the variability of the drugs, what are the mutants which are prevalent, and now they with the COVID thing, is the isolation practices being followed or not. So member secretary has to be somebody from the microbiology department. Then the third most important person is clinical microbiologist or the infection control officer, जिसे हम कहते हैं. Here there is a thing we talk about, if it has to be a microbiologist or it has to be somebody from the infectious diseases subject. Yes, it can be considered either a person from ID or a person from microbiology can be infection control officer. Preferably here also microbiologists are given a chance, again helping the member secretary to know about the antibiogram, to know about the prevalent drugs, to know about the hotspot areas, because infection control officer along with the infection control nurses, they and a person from GDA staff and one person from operations can help them out to form a infection control team which works on day-to-day basis, which I'll be talking later in this presentation of mine. Then is the infection control nurse. Without this person, without this eligibility, any hospital infection control committee is just incomplete. If you don't have an trained infection control nurse, not that a simple, the one who is working in our wards, simple nursing cannot help. Somebody who has a vast knowledge, somebody who has done courses on infection control, those are the people, they are very helpful to formulate important role as infection control nurse in the hospital infection control committee, because these are the people जिन्हें daily rounds पे जाना होता है, daily checklist देखनी होती हैं, daily practices को improve करना होता है, daily practices को देखना है कहाँ कमी आ रही है हमारे पास. And further the strengthening part of HICC is trainings, हर जगह पे जहाँ पे training लेनी है. So at a ground level, if at all we see the infection control nurse only will be the person who can help us out in our day-to-day practices. Then comes people from maybe the head of in charges of the units or head of the Department of Medicine, Surgery, from the allied sciences. Director of nursing or the nursing superintendent plays the prime role, because they are the people जो हमें help करते हैं to accommodate all the nurses at one platform, that yes, these are the practices which are need to be followed in our system to improve the practices, to improve the checklist, improve the bundle care branches, what they are doing on day-to-day basis in their wards, in their ICUs or in their operation theaters. Occupational health physician is nothing but a person for infectious diseases. I don't know how many hospitals do they have it. We have one ID specialist in my hospital, and quite a help for us. Wherever we are in crisis, I think this person helps you out to get out of the problem or to eliminate the infections. Then representative from the major clinical specialties, as I said, some people from super specialty branches, like either it is CTVS or it is neurosurgery or it is neurology. Oncosurgery plays a vital role because they have maximum of the terminal patients coming from Bathinda, because yes, we have a cancer belt and n number of cancer patients are there with us. So my oncosurgeons plays a very important role in improving the infection control practices, and they are a major part of my HICC in my hospital. Then the other representatives from departments, like as I said, head of operations should be there in your day-to-day activities, because they will be able to pinpoint the lower junior staff how to arrange and how to get the problem solved. Pharmacy, when we talk about antimicrobials, are they getting the list of antimicrobial restricted antibiotics? Are they getting an extra copy of it? Or any misuse of antibiotics is not going on, or over the counter supply of drugs is not available. So that accountability has to be given by a pharmacy people. Then CSSD, आपके जितना OT का सामान है, from the wards, from all the places, what all your basic surgical prophylaxis के लिए, whatever sets which are sent to the OT during the procedural time, I hope they are being sterilized, they are being ETO हो रहा है, and proper biological indicators are being used, and the quality check is being done, whether the sets which are being provided to the OT are suffice or not. I hope they are maintaining their records. Then person from maintenance, बहुत कई बारी neglected. Maintenance and housekeeping are the neglected parts at times, but people say that yes, हो जाएगा. No, this is not practically in ground. अगर आप देखें तो day to day and every shift में इनका होना बहुत ज़्यादा ज़रूरी है. Not that one person is only adhering to their restricted parts, but they have to look into the cleaning, the proper cleaning, whether the disinfection what you are using is appropriate or not, whether cleaning at the areas, mops which are being used are practically sound enough or not. So ये सारी चीजें in detail Dr. Suchitra will be taking, but basics I am telling you, these people formulate the infection control committee. With either of one which is missing in this whole list won't be able to suffice the HICC. So hospital administrator for all the queries, हमारी सारी problems जिसको हम सुना सकते हैं, that has to be there, whether it's administrative role, whether it is a financial role, whether it is a legislative role. They play a very crucial role in formulating the chairperson of Hospital Infection Control Committee, member secretary and the infection control officer for the day-to-day activities which are being done along with the infection control nurse, physicians, surgeons, people from the super specialty, nursing superintendent, and other representatives, operations, pharmacy, CSSD are the key members to hold on this hospital infection control committee. So these prime members are required for HICC. Then we move on to the infection control team. As I said that कि आपका जो ICO है, either it can be a microbiologist or a ID specialist, but preferably microbiologist, because what are the daily day-to-day organisms which are being prevalent can only be helpful for you people, that what are the predominant organisms and what are the hotspots. ये आपको day-to-day practices में only a microbiologist can tell you, because yes, they report on day-to-day basis. Then the infection control nurse. Here I need to ponder, in bigger institutes, in bigger hospitals where the number of beds is more, one ICN is required for 250 beds. So according to the availability of your beds and according to your requirement, I think you should formulate. Mine is a bigger institute, so we have almost 3 infection control nurses with us. And yes, ICT members from day-to-day activities, they work for the proper functioning of the infection control committee. Then the third part in this is the infection control manual. आपने पूरी कमिटी फॉर्मुलेट कर ली है, आपकी डे टू डे प्रैक्टिसेस के लिए आपके पास एक टीम अवेलेबल होगी ये 3 से 4 लोगों की. What to do further? आपको पता है कि आपको करना क्या है, but at the same point of time you just know it. It's just a thought. Do you have a document for this? NABH always talk about documentation. Why not? Why NABH? In fact, NABL also talks about documentation. So जो भी आप practices कर रहे हैं, if you don't have a document for this, I think your purpose will not be solved. So for that, you need to have an infection control manual. That is why it formulates an infection control program. ICP में ये 3 चीजें आते हैं. आपने एक कमिटी बना ली है, आपने डेली काम करने वाले लोगों की एक वो बना ली है, देन आपके पास एक मैनुअल होना चाहिए कि जो भी आप प्रोसीजर्स या जो भी आप एक्टिविटीज करवाना चाहते हैं, you need to have a version to it, that yes, these are the protocols what we follow. This is also a very common query whenever we go for any platforms on HICC. People ask us that, ma'am, what actually formulates the infection control manual? So I'm just helping you out to formulate how do we go for of making of a manual. सबसे पहले तो हमारे पास organogram होना चाहिए of a hospital. What is the meaning of organogram? From your hierarchy to the lowest person who will be reporting to whom should be available in your infection control manual. As I said about HICC, एक hospital administrator होना चाहिए, उनके नीचे then is a second in command is member secretary, then comes the day-to-day officers who work for day-to-day practices. So that organogram has to be filed up in your infection control manual also, even at the starting point of your hospital, so that it is easy for anybody to know. Somebody who comes from NABH can definitely have a look into it and say that, okay, fine, you have an organogram. It's easier to find out whom to address which problem. So organogram for a hospital is required. Then the first chapter should be the risk categorization of your hospital areas. Why risk categorization? I think अभी तक हम बात कर चुके हुए हैं. It's been 2 years. Exactly the second anniversary of COVID is there with us. Second lockdown anniversary is there in March 23rd. So risk categorization हमारे hospital में होना बहुत ज़्यादा ज़रूरी है. Where all people, like for COVID only, if at all we talk about, do we have isolation areas? Which are the floors or which are the areas you have demarcated for risk categorization? What were the practices which were being followed in your risk areas? So उन सारी चीजों के बारे में बात करना चाहिए. And yes, in risk areas, your OTs will be demarcated differently, your wards will be demarcated differently, and your isolation or barrier areas will be demarcated differently. Then the surveillance mapping of the risk areas. Surveillance जो 4 इंडिकेटर्स की मैं बात करूंगी फर्दर उसके बारे में, so उसकी एक मैपिंग होनी बहुत ज्यादा जरूरी है. Hand hygiene, I think I don't have to mention it out here. Hand hygiene, how frequently this word has been used in this past 2.5 years when we were dealing with this COVID. Standard precautions, hand hygiene के साथ साथ what are the 5 moments of hand hygiene? What are the basic prerequisites we require for dealing with the patient? What are the standard precautions we require? उसके बारे में एक documentation होना चाहिए हमारे पास. Isolation precautions, yes, we need to know what are the different isolation precautions. First and foremost being donning and doffing, which Dr. Suchitra will be dealing in detail. तो उसके बारे में आपके पास एक documentation होना चाहिए. High risk areas or your hotspots, as I said that if any bug has been prevalent in your ICU, what are the basic barrier methods or what are the precautions you have taken? Occupational exposure to blood and body fluids, any splash or any mishappening or any spill has occurred in your area. So how do you deal with it? उसको आप कैसे प्रोटेक्ट करेंगे and what are the basic precautions you are supposed to take? उसका एक documented procedure होना चाहिए. This part, recommendation of cleaning and disinfection. What are cleaning and disinfectants? What are to be taken? Dr. Suchitra will be dealing, but I'll tell you the main areas जहाँ जहाँ पे आपको सबसे ज़्यादा high mark out करना पड़ेगा. In your ICUs, in your cath labs, in your operation theaters, dialysis, critical and non-critical area. These are the areas where maximum your terminally ill patients or the maximum immunocompromised patients are there. So आपकी practices वहाँ पे ठीक हो रही हैं कि नहीं हो रही? So who's going to take care of that? Somebody from operations, somebody from maintenance and your housekeeping. So जब हम बात करते हैं HICC की, ये लोग यहाँ पे बहुत बड़ा रोल प्ले करते हैं. जो हम recommendations कर रहे हैं cleaning and disinfectants के लिए in hotspot areas में, are they being done on daily day-to-day basis? So who's going to check onto this? A part of HICC member has to, and the practices जो हो रही हैं daily, वो सही हो रही हैं कि नहीं हो रही हैं, वो ये लोग आपको बता सकते हैं. Very importantly, then we have the vaccination policy. Basic TT injection is given to all the ground staff who's working. Then hepatitis B, if it's a food and beverages areas where the typhoid vaccination has been given and most importantly आज की डेट में COVID vaccination हुआ है कि नहीं हुआ है. So vaccination policy, you need to have a vaccination policy by sitting along with somebody with HR. They can help you out, and from the administrative level you can look into the finances and plan for the vaccination policy for your healthcare staff in your hospital. Outbreak management, I think the world has dealt about how we all the hospitals at every level, whether it was a primary, secondary, or tertiary care hospital, how everybody has dealt this outbreak management. So आपने अगर कोई outbreak हुआ है, I remember there have been multiple advisories from the ICMR related to the infection control practices, what are to be followed. There were 3 advisories over this 3 years, which they took out mainly, and which strictly every hospital was supposed to adhere it. So how challenging it was and how you have managed this outbreak is also supposed to be jotted down in your infection control manual. Lastly, this point mortuary. This is maximum in the cases of medical colleges because yes, we have a setup of mortuary with us. So are the infection control practices being dealt there? The cadavers which are there, the tables, the cleaning practices, whether it is being followed very efficiently there or not. This point is mainly put up as per NABH standards of 5th edition. बहुत बड़ी ये पूछा गया है. In my last institute also, definitely this point was raised up. What are the infection control practices at your mortuary? In a hospital setup, they don't bother, but yes, with the medical college attached, they have asked, and इसके ऊपर एक NC जरूर लगती ही लगती है otherwise. So if I talk about a proper organogram for an institute, the risk categorization, the surveillance mapping, the hand hygiene practices with the standard and isolation procedural activities, isolating your high risk areas, any body splashes or fluids, then recommendations of what are the cleaning and the disinfectants we are using at the hotspots, vaccination policy, outbreak management, and lastly, for the mortuary healthcare practices, we need to address it. And those address things we need to address here. So moving on next, and yes, one word when we talk about how frequently the infection control meetings are to be held. See, mine is a medical college. Every quarterly we have a infection control meeting, and if it's a dire emergency, any time in a month you can have. If there is a challenge going on, like during the time of COVID, every month we were meeting, and obviously when the advisories were coming, every third or the fourth day we were looking forward for the infection control practices, whether it was being taken place or whether it was properly dealt or not. So for a bigger institute like mine, I can say quarterly. In a hospital-based setup, I think every month you should look into the infection control practices, and the HICC meeting should be held where you can talk about what are the surveillance rates. In my hospital, since we are meeting quarterly, but every month we are taking out the report of uh, what are the surveillance parameters, what are the indicators, and how much is the percentage as per the NHS standards and as per the Indian standards. So moving on, next we have what are the functions of HICC. As I have been talking कि मैं बार बार सर्वेलेंस की बात कर रही हूँ, ये आज की टॉपिक का सबसे बड़ा और अहम पार्ट है. पहले तो मैंने आपको सिर्फ ये बताया है कि what formulates your HICC प्रोग्राम. हॉस्पिटल इन्फेक्शन कंट्रोल प्रोग्राम में आता क्या है? एक आती है कमिटी, एक आती है टीम, और एक आता है मैनुअल. अब इसके आपकी जो HICC है उसके मेन फंक्शंस क्या हैं? पहली बात तो ये जो सर्विलेंस डाटा की हम बात कर रहे हैं, जो 4 मेन इंडिकेटर्स की हम बात कर रहे हैं, इनको आप कैसे चेकआउट कर रहे हो, इसका डाटा आप कैसे एनालाइज कर रहे हो, और एनालाइज करके हाउ मच यू आर एबल टू रिप्रोड्यूस इट टू योर मेन पीपल, मेन कमिटी मेंबर्स, सो दैट आपकी प्रैक्टिसेस इंप्रूव हो पाए. Then comes policy making and proper antibiotic usage. हो रहा है कि नहीं हो रहा है? In your policy making, your daily SOPs, also the formulation of your infection control manual, which annually should be changed as per NABH 5th standard. पहले 4th standard follow होता था. आज की डेट में NABH is just following the 5th standard, though the parameters have been reduced, but they have much more led into excellence. Then implementing antibiotic stewardship program. This is one challenging part. Whether you talk about a medical college, National Action Plan for Antimicrobial Stewardship has also been started by the National Medical Commission. NMC ने भी ये start कर दिया है कि antibiotic stewardship program को हम लोग कितनी seriously ले रहे हैं. Antibiotic stewardship, right antibiotic, right dose, right drug, are we giving it, and right patient को मिल रहा है कि नहीं मिल रहा है, and what are the proper usage of antibiotics which is being used in an institute. For that we have to talk about. And what are we doing for training our people, whether it's our faculty members, whether it is a healthcare worker. Then outbreak management. This has been an important part of HICC. अभी COVID has been the recent outbreak to all of us. So I think all of us in the hospital or the medical colleges, we have designed it well. One point, the important part of function as a function of HICC, आपकी review meetings होनी बहुत ज़्यादा ज़रूरी है. As I said that, how frequently you are conducting your HICC meetings, this is important. How in a quarterly basis पे कर रहे हैं, आप monthly basis पे कर रहे हैं, what are you reviewing in that? आपने indicators के बारे में बात किया है, अगर आपने indicators के बारे में बात किया है, how much is the prevalence data which is there from your institute? I think that should be documented and that should be submitted to NABH, so that with that accountability we can have some Indian standards for it, for the main indicators what we have. हेल्थ केयर एसोसिएटेड इन्फेक्शंस का सर्विलेंस डाटा, इसके सबसे ज्यादा प्राइम पैरामीटर्स कौन कौन से हैं? वन इज कैथेटर एसोसिएटेड यूरिनरी ट्रैक्ट इन्फेक्शंस, then the other is central line associated bloodstream infections, the third one is ventilator associated pneumonias, and lastly we have the surgical site infections. One by one I'll be dealing with it. Talking about what is the definition of surveillance, coming from a medical background, yes, हमें बहुत in community medicine पढ़ाया जाता था what surveillance means. It used to be a definition of almost 4 to 5 lines, but to very shortly, how do you define it? This triangle is very well defining it. आपने एक किसी भी चीज का, let's talk about any parameter. If we talk about ventilator associated pneumonia, you have a data, you have got the endotracheal intubation, उसके secretions अगर आपके पास आए, आपने वो आपके उसके other clinical parameters like what have been the PEEP value, what is the FiO2 value, what is the clinical parameters, what is the total leukocyte count, what is the X-ray film, what is it is treating. So आपने वो पूरा data collect कर लिया. You have the data with you, but you have to study that, whether there is any organism which is prevalent, whether the chest has got infiltrates, whether the TLC count is increased. So उस पूरे डाटा को consolidate करके you have analyzed that yes, this is probably a multi-drug resistant Klebsiella pneumoniae which is causing a ventilator associated pneumonia. So you have collected the data, you have viewed and consolidated it, and finally you are coming to a parameter and analyzing that yes, this is my bug. Let's say talk about multi-drug resistant Klebsiella pneumoniae is the culprit, and we have to take necessary actions. So अगर आपने इन सबको लेके इसकी इम्प्रूवमेंट के ऊपर काम नहीं किया कि ये MDR क्लेप्शिला अगर आया है तो कहाँ से आया है, मे बी सम हैंड हाइजीन प्रैक्टिसेस बैरियर हुआ है, मे बी द एंडोट्रेकियल इंट्यूबेशन जो हुआ है दैट हैज नॉट बीन डन अंडर स्टेराइल प्रिकॉशंस. So whichever has been the challenge or the root cause analysis, you have to pick up that and improve that practices so that it doesn't happen to a second patient. As a word I said healthcare associated infection, patient आया एक बीमारी के साथ था, he has been intubated, but at the same point of time वो किसी एक वाई डिजीज को लेके उसको एक MDR क्लेप्शिला निमोनिया अलग दे दिया है हम लोगों ने. So that is a challenge. ये नहीं होना चाहिए, उसी के लिए healthcare associated infections की prevention is very very important. So collecting, consolidating, analyzing the data, and finally improving the practices so that these HAIs are not burdened up to the hospital is our main aim, and that is the meaning of surveillance. So talking about the first surveillance indicator, this is catheter associated urinary tract infection. To define with catheter associated UTI infections, we have two words in this. One is asymptomatic catheter associated UTI or symptomatic, ABUTI and SUTI, SUTI. These are the two words which are important. But सबसे पहले अगर हम बात करें, what is COTI, catheter associated UTI? So you have an indwelling catheter which has been inserted in situ to the person, and it has been kept for more than 48 hours. And taking the date day 1 as जब हमने catheter डाला है, that is picked up as day 1. So that adheres to the catheter associated urinary tract infection. So you have an indwelling catheter, that is catheter in situ, more than 48 hours which has been placed. When you have placed this, the device का day 1 जो है, आपने उसी time urine sample भेजा है to the microbiology lab, and that is sterile. This has to be the catch. आप ये नहीं कह सकते 48 hours के बाद कि yes, now this जो हमारे पास कैथेटर लगा हुआ है and उसमें E. coli आ रहा है. Did you send the baseline culture? If the answer is no, it is very challenging for us to label it as catheter associated UTM. So you need to have a baseline culture, whichever parameter you're talking about, आपको एक baseline culture उसका भेजना पड़ेगा. So अगर baseline culture में organism आ रहा है with indwelling catheter, along with that, let me go into a systemized thing. What is symptomatic urinary tract infection? Word itself defines it. Symptomatic, पेशेंट को सिम्टम्स है. सो इनड्वेलिंग कैथेटर इन सीटू भी है, 48 आवर्स भी हो चुके हैं, डे 1 हमने डे ऑफ प्लेसमेंट ले लिया है. अपार्ट फ्रॉम दैट, वन ऑफ द साइंस एंड सिम्टम्स दैट इज ईदर फीवर इज देयर, costovertebral angle pain or tenderness is there, and culture is positive for particular organism with a significant bacteriuria, that is considered to be as symptomatic urinary tract infection. If such criteria are fulfilled in any patient, we need to have a look into it, that probably the patient has landed up into, patient आया किसी और बीमारी के साथ था, but because of his adherence, he or she cannot be, was not able to pass urine, so we have catheterized the patient because of its comorbidity. But एक ट्रीटमेंट को ठीक करते करते उसे कैथेटर एसोसिएटेड यूटीआई भी हो गया है. सो देयर अराइजेस द हेल्थ केयर एसोसिएटेड इन्फेक्शन, right? And what is asymptomatic urinary tract infections? Asymptomatic bacteremic urinary tract. So with or without inhaling catheter, signs and symptoms नहीं भी हुए. Asymptomatic word है, कोई signs and symptoms नहीं है, कोई urgency नहीं है, frequency dysuria, nothing is there, right? Especially in pediatric age group, इस चीज को आप consider कर सकते हैं, very commonly seen, but the culture has to be positive, that is with significant bacteriuria, 1 lakh colony forming unit per ml, and एक 2 microorganism अगर आ रहे हैं, still can be taken up, but more than 2 bacteria, if at all it is there, we will try to have another repeat sample and look into the matter whether it is actually a booty or not. If it is more than 2 organisms, I think we should surely go for a repeat sample. So we have symptomatic urinary tract infection, we have asymptomatic bacteremic urinary tract infection. So that defines your catheter associated urinary tract infection. I think there are books which goes into much of detail, but mainly you need to know this, what exactly this catheter associated urinary tract infection comprises of. Indwelling catheter होना जरूरी था, उसमें साइंस है तो सिम्टोमेटिक हो जाएगा, विद नो साइंस है तो एब्यूटिक हो जाएगा. But apart from that, there has to be an organism which is prevalent and with a significant bacteriuria, we need to consider it as catheter associated urinary tract infection. So per day 5% and 1 week में 25%, it is a very commonest risk and multiple studies have been shown जहाँ पे ये parameters दिखाई जाते हैं. The most commonest catheter associated urinary tract infection में the most commonest bug are E. coli. Then comes the other enterobacteriaceae family organisms like Proteus, Klebsiella, and some gram-positive organisms like Enterococcus, Staphylococcus, and Staph epidermidis. For an antenatal case, I think Staph saprophyticus is a very commonest organism which causes urinary tract infection. But if any patient with comorbidity has been catheterized, can lead up into catheter associated urinary tract infection. So how do we do the surveillance? हमें पता चल गया ये catheter associated है urinary tract infection. हमने इसका आइडेंटिफाई भी कर लिया है, माइक्रो ऑर्गेनिज्म भी हमें पता चल गया है, इसके सिम्टम्स भी थे, अगर सिम्टम्स नहीं थे, स्पेशली इन द पीडियाट्रिक एज ग्रुप, हाउ डिड वी डिफाइन इट? सो फर्स्ट ऑफ ऑल, हु टेक्स अप दिस डाटा कलेक्शन? डे टू डे, एज आई सेड दैट, डे टू डे जो ग्राउंड लेवल पे काम करेगा वो आपकी इन्फेक्शन कंट्रोल नर्स है. How do he or she will check it? You will have a bundle checklist of all these things. You will have the data sheets which you have to fill up on day-to-day basis, and that thing has to be picked up to the microbiologist or the infection control officer so that they have an isolation of the thing and they can label such a patient is definitely going into catheter associated urinary tract infection. So here the prime role is played by your ICN, he or she is collecting the data. And how do you calculate the COTI rate? So number of urinary catheter cases हमारे पास उस month में कितने आए हैं, divided by the denominator has to be number of urinary catheter days in a month multiplied by 1000. Generally, I think the 1.63 से लेके 2.1 per 1000 catheter days it has been taken. And in India, it seems it is said that 0.3 to 1% in IPT cases, COTI rate is seen. So basically what I'm talking about is CDC and NHSN guidelines या उनके standards जो हैं, which is 0 to 5.3 cases in a month That's what CDC has defined it in 4 years back. बात कर ली हमने कैथेटर एसोसिएटेड यूटीआई की, बट ये इसको प्रिवेंट कैसे कर सकते हैं? वी हैव डायग्नोस्ड, रूट कॉज एनालिसिस करेंगे. रूट कॉज एनालिसिस से आपका ये मेथड होगा दैट we are not giving it further to any other patient. So we have two strategies for that. One is a core strategy, the other one is a supplemental strategy. Core strategy, first of all, identify the person, the indication given कि इसे किस patient को आपने catheter insert करना है नहीं है. That is the core strategy of COTI you have to follow. It is recommended to minimize the use of catheter in all patients. खास करके आप उन्हीं पेशेंट्स के लिए कैथेटराइजेशन का सोचें, either elderly or immunocompromised है. What is the comorbidity for what we have to put it? Otherwise, any random patient, don't go for it. Don't go for the catheter insertion for a female. This is the bundle checklist. हम लोग जो बात करते हैं, COTI insertion checklist है हमारे पास. So in that we have date of catheter insertion, time of catheter insertion, who has done it, because the blame game cannot go on and on. You need to have the name of the person who has actually inserted, ID, employee ID, then signature of that person. What is the designation? I hope it is a trained nurse who has done that. What time? अगर by chance catheter removal की बात हो गई है तो what time the catheter has been removed. And towards the right hand side is the prerequisition of all the patient के requisites हमें चाहिए. What is the age, sex, what is the ID number, IPD में अगर है, date of admission कब हुआ था. Catheter insertion and date of admission can be different. 2 दिन के बाद, because of the comorbidities of a patient, we can decide that yes, this patient can go for catheter insertion. So ये जरूरी नहीं कि ये हमेशा same हो. Catheter insertion के time पे आपने baseline culture भेजा है कि नहीं भेजा, that is also one of the prerequisites what we follow in catheter insertion. So before the procedure करते हुए और after the procedure जो आपको basic precautionary actions लेने हैं उसके बारे में लिखा हुआ है. And there has to be a second person who is standing along with the nurse who can take all these things. That whether these things, it's not that कि एक paper लिया हुआ है आपने सब में yes कर दिया. These are not the practices you need to follow. In a good institute, in a good NABH going off-site or already NABH accredited institutes, this does not follow. You actually have to look into the thing that whether these practices are being followed or not. So indwelling catheter की पहले तो indication क्या रही है वो देखनी है हमें. क्लिनिकल रीजन की अगर हम बात करें, जो डाल रहा है, प्रोसीजर कर रहा है, वो बंदा कॉम्पिटेंट है, ट्रेन्ड नर्स है कि नहीं है, पूरा पेशेंट को एक प्रोसीजर एक्सप्लेन करा गया था कि नहीं करा गया था, whether all aseptic precautions has been followed or not, smallest of the gauge has been used or not, balloon की capacity क्या है when you are using these are the very basic things what you need to know. And confirm history, अगर कोई मेल पेशेंट है, BPH की कोई हिस्ट्री तो नहीं है, कोई यूरेथ्रल स्ट्रिक्चर तो नहीं है, पहले अगर कभी, बिकॉज यू हैव पेशेंट्स विद मल्टीपल कैथेटराइजेशंस आते हैं उनके पास, एंड कई बार चेंज करवाने के लिए आते हैं, सो यू नीड टू हैव अ प्रायर कैथेटराइजेशन की एक स्मॉल हिस्ट्री आप पूछ सकते हैं. सो यू नीड टू टिक ऑन द थिंग्स व्हाट यू हैव फॉलोड, yes or no. Just don't say that, as I'm again mentioning and pondering onto it, please आप directly उसको yes मत कर दीजिएगा, because that will not suffice the help. आपको मतलब उसकी कोई वैल्यू नहीं पता चल पाएगी. अगर आप प्रैक्टिसेस को अच्छे से फॉलो करना चाहते हैं, प्लीज मेक श्योर दैट व्हाटएवर इज adhere to the system, that only you are doing it. And during the procedure, whether properly उसको sterile area के साथ आपने किया था, lubricate किया था कि नहीं किया था कैथेटर को, whether the drainage bag has been properly attached or not, gloves पहने थे कि नहीं पहने थे, कि without gloving only the catheter has been inserted or not. And after the procedure, proper padding, and you have isolated that area, and the trip between the urinary bag that has been properly placed it or not, or invasive वगैरह अगर आपने हमें कोई भी procedure करा है, hand hygiene करा था कि नहीं करा था. So all these practices, the side by person who is standing there, probably again a trained nurse, will be able to help this to fill up the checklist, right? Again, the valid reason for catheterization, ये सारी की सारे points आपको उसमें identify करके note down करने हैं, and then only you should tick it, right? We were talking about the core strategies. Leave catheters in place only as long as needed. So कोशिश यही रहती है कि 24 hours से ज़्यादा अगर post operatively नहीं required है, you can take out the catheter and then so that the patient is asked for general voiding of the urine. Ensure that only properly trained persons, yes, I've already said that the checklist has to be filled up by some trained person only, not that one fine day you're collecting almost 10 sheets and then you're putting yes, yes, yes. That practice is completely a no-no from us. In my institute, a NABH accredited institute, we don't follow all these things. And insert catheters using aseptic technique, we've already discussed in the checklist, that bundle checklist जो मैंने आपको बताई है. So that has to be properly taken care. The cleaning of the periurethral area has been done. Proper gloving हुआ है कि नहीं हुआ, jelly जो use कर रही है, whether lubricant jelly was used or not. And when you're cleaning and when you're securing the catheters, please look into that, whether it has been done successfully and correctively, or else it is just laying down like that only. Then some other nurse will come and push into the thing, which will again lead up into some other microorganism prevailing into the urinary bladder. Right? This is the day-to-day infection control daily surveillance है हमारा. If you can see that, हमारे पास ये यूरिनरी कैथेटर के लिए भी है. वी हैव फॉर सेंट्रल लाइन, फॉर वेंटिलेटर. यू माइट बी थिंकिंग कि मैडम आप जो ये डेली सर्विलेंस मैटर दिखा रही हैं तो सारे के सारे का दिखा रही हैं. सो मैडम दिस इज अ वेरी कॉमन, हमने एक जर्नलाइज पूरा परफॉर्मा बनाया हुआ है फॉर urinary catheters also, for central lines also, for ventilators also. We are putting up this one only, and on for how many days the catheter has been in situ, उसके basis पे आपको ये checklist पे सिग्नेचर करना है. एंड दिस हैज टू बी फिल्ड बाय योर इन्फेक्शन कंट्रोल नर्स. जो पहले मैंने आपको चेकलिस्ट दिखाया था, दैट हैज टू बी डन बाय द पर्सन हु इज डूइंग इट, अलोंग विद दैट सम अदर पर्सन हु स्टैंडिंग अलोंग विद इट, वो डाल सकते हैं. यस, देयर इज वन कैच इन दिस. अगर आपके इंस्टीट्यूशन में कोई 10 से 20 कैथेटर्स, इफ इट्स अ बिगर इंस्टीट्यूट, सम 10 catheters are being placed at different areas of your institute. So either of one place or two places, infection control nurse and go and have a look into the thing, whether this is being followed or not. How do you audit it? आप कोई भी चीज अगर आप करने जाते हैं, like let's say that in a medical college, if at all you're taking exams, so how do you assess the students? By examination. So same way, आपकी nursing staff सही से काम कर रहा है कि नहीं कर रहा है. So to have an audit for that on daily basis, your infection control nurse can go at one particular place. And yes, let's say in a CTVS area, some catheterization was being done. So he or she can have a checklist in his hands, and he can check out that whether the bundle checklist की जो हम बात कर रहे हैं वो follow हो रहा था कि नहीं हो रहा था. And this is the infection control daily surveillance data which your infection control nurse has to follow. Right? And this is हमारा catheter associated. अगर by chance हमारे पास organism आता है, so event जब हम record करते हैं, how do we record it? So this is again the patient पूरा demarcation. Then urinary catheter for more than 2 days हमारे पास था या नहीं था, कब insert हुआ था, where was the catheter, like OT में place हुआ था, whether it was in the ward, date of removal, right? Whether it was symptomatic or asymptomatic, and lastly, what is the organism with significant colony forming unit, what do we have? And if it is 2 organisms, you should isolate the 2 organisms and write the name with the antibiotic sensitivity pattern. But if it's more than 2 species of microorganism, please, again, I'm recommending as a microbiologist, please go for a repeat sample. Right? Apart from that, any other bloodstream infection is there or not? So this is how you fill it. And apart from that, we have another performer where we fill up what could have been the root cause of analysis. कि इसका reason क्या रहा होगा, whether core strategy में या preventive strategy में कहीं ना कहीं breach हुआ है, किसके कारण ये catheter associated urinary tract infection हुआ है. So idealizing that, that is how the story of catheter associated UTI is formulated and looked into it. Right? So moving on, next we have ventilator associated pneumonias. I hope I am able to hear everybody out. Then comes the, I hope I'm audible to everyone. Somebody please admit yourself and can, oh fine. Okay, then we have ventilator associated. This is the second most important parameter and second very commonest reason of healthcare associated infections. We have ventilator associated pneumonias. Okay, so this is how a normal lung looks like, and this is the other side, the right hand side is your VAP lung, which looks like, right? Very quickly, if at all I define what are ventilator associated pneumonias, they are defined as pneumonias that occur for more than 48 to 72 hours, mainly 48 hours, 2 दिन से ज़्यादा अगर कोई endotracheal tube रखी हुई है. Along with that, you have progressive infiltrates on the chest X-ray. देन यू हैव सिस का आपका कोई वो ऑल्टर्ड मैकेनिज्म लाइक फीवर हो सकता है, increase in WBC count, then changes in the sputum characteristic or the ET secretions, and detection of a causative agent, which is nothing but your microorganism which have been prevalent during that time. So उसके बारे में आपको बताना बहुत ज़्यादा ज़रूरी है. So more than 2 days ET ट्यूब डली हुई है, उसके secretions अगर आपने भेजे हैं तो उसमें कोई organism isolate हुआ है, chest x-ray पे infiltrates आए हैं, fever, any signs and symptoms of fever, leukocytosis, then followed by that any changes in the secretions of the sputum, it is considered to be as ventilator associated pneumonias. There are different terminologies for when do we call as ventilator associated condition. Then we have the infection related ventilator associated complication, IVAC जिसे कहते हैं, and third one is the possible ventilator associated pneumonias. So पहली अगर हम बात कर रहे हैं कि सर्वेलेंस ऑफ एल्गोरिदम अगर आता है, फर्स्ट इज मैकेनिकल वेंटिलेशन क्राइटेरिया, उसमें कुछ भी नहीं है, पेशेंट जो है वेंटिलेटर पे है इन प्लेस फॉर 2 days और मोर, इफ इट इज रिमूव, डेट ऑफ इवेंट अगर हम देन द डेट ऑफ इवेंट मस्ट बी ऑन द डे 1 ऑफ रिमूवल और ऑन नेक्स्ट डे, राइट. बेसलाइन पीरियड की अगर हम बात करें उसकी हम डिफाइन करेंगे अगेन 48 आवर्स के बाद, और डिक्रीजिंग इन FiO2 और द पीप वैल्यूज हम करेंगे. Now talking about when do we call it as ventilator associated condition, अगर daily FiO2, I think मैं पहले आपको ये दिखा दूं. Okay, let's talk about first of all early onset VAP. So mainly what are the organisms which causes early onset VAP is Klebsiella pneumoniae, and that is multi-drug resistant Klebsiella pneumoniae. Then you have the other Enterobacteriaceae family organisms like E. coli, Enterobacter and Serratia. Methicillin sensitive Staph aureus, again one of the commonest early onset VAP may cause karta hai, and sometimes Streptococcus and Haemophilus influenza are also the organisms. These are some gram positive, and Klebsiella and other Enterobacteriaceae family organisms are nothing but this early onset ventilator associated pneumonias. Then we have late onset, we have MRSA, Acinetobacter pseudo. Mainly non-lactose fermenters are the ones which causes late ventilator associated pneumonias. There are definitely fungal and viral causes also, especially fungal में Candida albicans has been the cause, and aspergillosis, invasive aspergillosis had been a very big challenge for the doctors nowadays to deal with ventilator associated pneumonias. What I'm talking about was CPIS score, clinical pulmonary infection score. This is very important. There are ideologists who say that this is of not much importance, but no, to deal with VAP, to isolate or to go for the surveillance of VAP, the CPIS score plays a very important role. So what are the 5 parameters what we look in CPIS score? One is the temperature, fever hai ki nahi hai, how much is the degree of fever which has increased. Leukocytosis, normal hai, you don't have to do anything with it. Anything which is ranging between 4,000 to more than 11,000, it is 1. And agar band cells दिखाई दे रहे हैं तो definitely it is 2 scoring. Then look at the secretions. अभी हमने बात करी थी कि sputum characteristic और endotracheal secretions का characteristic जानना बहुत ज़्यादा ज़रूरी है. If there is a mild watery solutions, you don't have to do anything. But if it's mild or non-purulent, 1. If it's purulent, thick, yellowish or greenish color purulent secretions are there, label it as 2 scoring. Then the radiographic findings, whether the patient is having no infiltrates, of course 0, patchy infiltrates or localized infiltrates, according to that we score. Cultural characteristics, आपके पास as I said purulent non-purulent secretions है, growth ही नहीं है, otherwise mild or florid growth is there, 1. Moderate or more than 10 to the, there are different papers which have shown, I can agree to it, that endotracheal secretions में there are students who come to us, they say that ma'am only significant bacteriuria हम लोग count करते हैं, सिर्फ urine में ही colony forming unit हम लोग देते हैं. No, if you are dealing with something like endotracheal secretions, please try to help your doctors out and try to give the colony forming unit for endotracheal secretions also. ET tube और बाल में भी आपको colony forming units देना आज की डेट में mandatory है, so that tomorrow when you will go and have a look have a look into your daily to daily activities. So you can find out that yes, the bundle checklist shows that this is a colony forming unit. More than 10 to the power of 2 is also important for the endotracheal secretions to have. Then there are two methods, roller methods or Bruy-Bunsen's method. That's how you can follow. For that we have another separate class on microbiological parameters, how to assess it in your laboratory. You can attend that and we can help you out how to isolate VAP and how to isolate endotracheal secretions, how to look for the growth of endotracheal secretions. Sometimes again यहाँ पे मुझे फिर से point करना पड़ेगा, when you are intubating the patient, at that time only you need to send the baseline cultures. अगर आपने किसी पेशेंट को इंट्यूबेट करा है, उसके secretions अगर आपने माइक्रोबायोलॉजी लैब में भेजे हैं, that is day 1 at the point of the time when you are inserting it. So उस time पे अगर secretions are sterile, there is no growth, so we don't have to do anything. But after 48 hours for the same patient, if you are sending the secretions, then आपके radiographic finding and tracheal secretions में भी अगर changes आ रहे हैं, then label the patient as VAP. Otherwise, don't say that that patient is going into VAP. One word what I was talking about, and of course lastly FiO2 values, patient is in ARDS or patient with ARDS, more than 250 value अगर है, so consider that patient is going into ARDS. So ventilator associated pneumonias में FiO2 values और P values देखते हैं. Infection related में नाम से ही पता लग रहा है आपको, यहाँ पे CPIS scoring की वैल्यू बहुत वैल्यू करती है कि आपने क्लिनिकल फीचर्स भी देखने हैं, आपने टेम्परेचर भी देखना है, आपने WBC काउंट भी देखना है, आपने ट्रेकेल सिक्रीशंस के कलर भी देखने हैं, फॉलोड बाय दैट कल्चर सेंसिटिविटी पॉजिटिव है और वेदर देयर इज नो कल्चर. बेसलाइन कल्चर भी स्टेराइल है, 48 आवर्स के बाद भी स्टेराइल है, यू विल नॉट लेबल द पेशेंट एज वैप. बट अगर बेसलाइन कल्चर पे अगर पॉजिटिव आ गया है, अगर उसके बाद तो आएगा ही, सो देन यू कांट लेबल द पेशेंट. अगर at the baseline it is clear and 48 hours के बाद there is an organism, consider it as a patient of ventilator associated pneumonia. and हम possible VAP कब हम लोग कहेंगे, IVAC वाले criteria वही temperature and WBC count and antimicrobial, and followed by that कुछ अगर नॉन कल्चरल मेथड्स अगर हिस्टोपैथोलॉजी या इम्यूनोफ्लोरेसेंस करा है वो भी अगर आ गया है तो दैट इज कॉल्ड एज PVAP, पॉसिबल वेंटिलेटर एसोसिएटेड निमोनियास. Okay. To note down here, scores can range between 0 to 12 and more than 6 अगर आपका ये CPIS score है, which I just said that temperature, leukocyte, tracheal secretion, radiographic finding, cultural characteristic and oxygenation status. अगर इनकी values 0 से लेके 6 तक है तो you don't have to worry. More than अगर 6 है तो please go for the presence of VAP. How do we go for the surveillance of VAP? So again, as the story begins, just like catheter associated UTI, here also in VAP rate, नंबर ऑफ वेंटिलेटर एसोसिएटेड निमोनिया केसेस पर मंथ, आपके पास कितने वैप के केसेस आए हैं, एंड द डिनोमिनेटर इज अगेन वहां पे कैथेटर एसोसिएटेड डेज थे, यहाँ पे नंबर ऑफ वेंटिलेटर डेज पर मंथ multiplied by 100 is your surveillance for ventilator associated pneumonias. There is no hitch and glitch. These are the only parameters you need to know. There are n number of documentation, n number of stories which prevail. बट आई थिंक अगर आपने इतना बेसिक कॉन्सेप्ट और अपने सर्वेलेंस पैरामीटर्स को इम्प्रूव कर लिया, आई थिंक यू आर गुड टू गो फॉर एनी NABH इन्वेस्टिगेशन. यस, आप वैप की बात कर रहे हैं, बट हाउ डू यू ट्रैक इट? तो आपके पास अपने इंस्टीट्यूट का एक VAE ट्रैकिंग शीट, जो आपका इवेंट है, वेंटिलेटर एसोसिएटेड जो इवेंट है, वो आपको आइसोलेट करने के लिए, आई थिंक somebody is scribbling onto the screen with some yellow color. I hope if at all you can just leave it. So you have the patient documentation, उसका डेट कब हुआ, again the third line if at all you can identify here, baseline culture आपने भेजा था, वो क्या आया है उसके बारे में पता होना चाहिए, patient डॉक्टर का नाम, who is treating the, what is the diagnosis can only be made, date of ventilation आपने कब डाला है, time, peak value क्या है, FiO2 value क्या है, total leukocyte count, what is the temperature charting, what are the antibiotic use, just with short forms you can write it, name of the isolate organism and antibiotic आपने कब start करी है. So here you can make out the diagnosis, for how many days patient is with there, it is just for 13 days I have written that. अगर उससे भी ज़्यादा beyond रहता है तो you can have the additional sheets for your institute. This is the same infection control surveillance data sheet जो मैंने आपको COTI के लिए भी दिखाया था. Here you can fill it for patient on ventilator, उसकी यहाँ पे आप पूरी की पूरी details डाल सकते हैं. whether the practices were followed, bed pens, urinals, hand rub हुआ था कि नहीं हुआ था, attach है कि नहीं है, how many times practices. Again, this is a duty of infection control nurse. Whenever a doctor or a junior doctor or a healthcare staff is coming to see the patient, to do any invasive procedure, to do any what do you say, that manipulation of the system what is there, so you need to have look into all these parameters, and you can address it as an infection control nurse, and then he or she can inform you to the infection control officer. So what is the treatment as we talk about? So these are for early onset web. We can use second and third generation cephalosporins, a set of fluoroquinolones, then beta-lactamase inhibitors or aminopenicillins, and the carbaphenamases. And treatment for late onset VAP, we have again cephalosporins, carbaphenamases, beta-lactamase inhibitors, and aminoglycosides. Here the part is, when we talk about late onset VAMs, sometimes these carbaphenamases are also resistant. Very many a days we see that. Those who have the automated system with them, Vitec agar unke paas hai, so for multi-drug resistance Klebsiella is a challenge for every doctor to have it nowadays. At that point of time, you can think about ceftazidime avibactam combinations, which is quite very helpful, and the MIC values are still lower. It has not gone into what do you say, MIC creeping yet. An anti-pseudomonal drug, a pair of fluoroquinolones or ceftazidimide, third generation cephalosporin, is quite helpful for treating such late onset VAP. So what is the prevention? Road rollers we do have, but is road roller को as infection control practices के लिए use करें तो ज़्यादा बेहतर होगा. How do we prevent it? 5-element VAP bundle. This is very, 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 very important. अगर आप अपने VAP के patients को remove करना चाहते हैं, to see that further आपके पास VAP cases ना हो आपके किसी particular area में. So this 5-element VAP bundle is very important. Oral care with chlorhexidine. PUD, peptic ulcer disease ना हो पाए क्योंकि patient is in a lying down position. Daily sedation assessment and spontaneous respiration के लिए आप उसे enhance करें. Deep venous thrombosis prevent, DVT में तो नहीं जा रहा patient, and head of the bed end of your patient's bed should be elevated. Here physiotherapy plays a very, very important role. To say that, first and the foremost, क्योंकि आपके patient intubated है, chewing नहीं हो पाएगी, there will be less of saliva, there will be obviously, as salivary agents are very good in fighting with the bacteria of our mouth. So for that we need to have proper chlorhexidine antiseptic. हमें washes के साथ patient की oral hygiene को maintain करना बहुत ज़्यादा ज़रूरी है. Many a times in hospitals it is neglected. We were overburdened. Nursing, one is to patient to nursing ratio काफी बड़ी कम होती है, so they were not able to perform it well. So उन cases में I think you should stringently observe and look into the areas जहाँ पे look into the areas when we have nurse into patient का relationship, ratio of the patient and nurse should be 1:1, so that one nurse is able to take care of one ventilated patient, and he or she can make sure that these 5 VAP bundle elements are adhered. So this is a ventilator bundle checklist. Oral care bundle, आपने उसकी cleaning practices, mouth की hygiene हुई है कि नहीं हुई है. Head end of the bed of the patient's bed is elevated, that is an acute angle अगर maintain हुआ है. Physiotherapy people have come down and just cuffed out at the shoulder or the back region, so that they're able, whatever the secretions are there, they're able to cuff it out. And daily sedation vacation from time to time, not that every time you have to sedate the patient, that habit has to be discontinued. जब भी आप उसे extubate करें, whether patient is able to cuff out the things. Then peptic ulcer disease prophylaxis in a lying down procedure, more of hydrochloric acid, HCl आपके बहुत ज़्यादा secrete हो गए and patient is dying of I have a pain abdomen, pain upper abdomen and GERD. So that has to be looked into it. And DVT prophylaxis, stocking, अगर if any chance patient has developed DVT, तो stocking उसको adhere किया जा रहा है, पहनाया जा रहा है कि नहीं. So all this bundle checklist has to be taken care into. Then how do you fill up this ventilator associated? This is the VA form of my institute, and I think again the other, just like other parameters, we have the patient requisites. कब आपने इसको ventilate करा है? It is a VAC, it is IVAC, or it is a possible VAP. अभी हमने बात करा था ना, वेंटिलेटर एसोसिएटेड कंडीशन है, इन्फेक्शन रिलेटेड है या पॉसिबल वैप है। तो कंडीशन में आपने पीप और FiO2 वैल्यूज देखी है, इन्फेक्शन में आपने पूरे पैरामीटर्स अलोंग विद द क्लिनिकल साइंस एंड सिम्टम्स एंड द ऑर्गेनिज्म देखा है, एंड पॉसिबल वैप इज नथिंग बट अलोंग विद कल्चर पॉजिटिविटी, कोई और ऑर्गेनिज्म तो नहीं ग्रो करा है, क्वालिटेटिव एनालिसिस, कॉलोनी फॉर्मिंग यूनिट भी आपको देना बहुत ज्यादा जरूरी है, और एनी नॉन कल्चर मेथड्स कि अगर इम्यूनोफ्लोरेसेंस पे या कोई रेस्पिरेटरी वायरसेस तो नहीं आ रहे। सो उसकी टेम्परेचर चार्टिंग आपने कर दी है, एनी माइक्रोबियल और एनी न्यू एंटी माइक्रोबियल एजेंट हैज बीन एडेड और नॉट। अपार्ट फ्रॉम दैट ये सारा का सारा क्राइटेरियन इसके फिलअप करने के बाद readily signed, and then you need to fill up this ventilator associated event form. This is how it looks like. So again you have the prerequisite of the patient, date of event, कौन सा culture आया है, what is the colony count. I am again specifying it. It is not only in the urine samples, in your bowel and in your endotracheal secretion samples also. You're supposed to give the colony count, and more than 10 to the power of 2, that is 100 colony forming units are also important for bowel or endotracheal secretion samples. Other cleaning complaints of patient during the time, diagnosis, that can be done with the help of any clinician, and mechanical ventilation pick up the temperature and TLC charting. Lastly, to get rid of any kind of infection, hand washing, hand washing, hand washing. It is the single most important method for reducing the transmission of pathogens. Yes, हमें हमेशा सुनाया जाता है क्या है बड़ी बात है, हैंड वॉशिंग की तो बात कर रहे हैं, बट अनफॉर्चुनेटली हाउ मेनी ऑफ द डॉक्टर्स, हाउ मेनी ऑफ द हेल्थ केयर स्टाफ, अगर आप रूट कॉज एनालिसिस कभी भी किसी सर्विलेंस पैरामीटर का या HII इंडिकेटर का निकालेंगे, सबसे ज्यादा इट इज लैक ऑफ हैंड हाइजीन प्रैक्टिसेस, लैक ऑफ हैंड हाइजीन मूवमेंट्स जो नहीं फॉलो होती हैं. So the only answer to this is repeatedly training, strengthening your HIC practices so that whenever they see, especially when they see the infection control nurse कि उस time पे सिर्फ hand hygiene practices कर रहे हैं, the answer should not be no. It should be the attitude of the person has to be changed कि आपको hand hygiene करना ही करना है when you're doing the when you're taking care of the patients. Moving on, next we have the central line associated bloodstream infections. Now this is something interesting. You need to hear this. One is CRBSI, that is used clinically for the laboratory diagnosis or the treatment purposes. तो ये आपको ध्यान में रखना होगा जब हम बात करेंगे, ऑन ग्राउंड बात करते हैं, it is CRBSI, that is catheter related bloodstream infection. And when you talk about surveillance, जब हम indicators को surveillance की checking करेंगे, that is called as central line associated bloodstream infection. Many a time students they approach us saying that, ma'am, is it a difference between CRBSI and CLEPSI? Yes, for surveillance you are supposed to use the word as CLEPSI, and for your general and for your routine microbiological laboratory purposes and for the treatment purposes it is catheter related bloodstream infections. How do you calculate it? I'll talk here only. Number of central line bloodstream infections divided by the denominator is again the total number of central line days multiplied by 1000. To define it, we have laboratory confirmed. I think word still says that again 48 hours ka hona chahiye, more than 48 hours it has been placed. Patient has been recognized with cultured blood culture की आपकी जो bottles आपने भेजी हैं, that is either of the one or more blood cultures are positive, and least at least one of the signs and symptoms, that is fever with chills and rigor, and positive laboratory report will result into catheter related bloodstream infection. Here the word has to be a paired blood culture. बहुत बारी पूछा जाता है what is paired blood culture. अगर आप peripheral भेज रहे हैं या central line भेज रहे हैं, whenever you are sending a blood culture in your setup, if the patient is fine, still you are trying to send कि patient कोई septicemia में नहीं है, every time you're sending a blood culture in either a conventional method or an automated blood culture bottle, please make sure you are sending a paired blood culture. दो bottles भेजनी आपको जरूरी है from right and left. Very commonly when we talk about CRBSI, what are the risk factors? तो तीन तरीके से होते हैं. या तो patient related हो सकता है, which defines either the patient is immunocompromised. Yes, he or she is a patient, might be immunocompromised. And as I said, I come from a cancer belt. So मेरे पास तो बहुत सारे terminally ill patients हैं, तो उनमें immunodeficiency is very common. Severe underlying illness or loss of skin integrity, old age patients. So they are the bigger challenge for you when it is patient related, and that would have led to CRBSI. Then we have the device related. What is the composition, what is the texture, what is the flexibility, what is, how many lumens are there, how many ports are there, from where the microorganism will have an entry to it, if at all any breach in the infection control practices is there. So कौन से device related problems हैं which can lead into CRBSI. And lastly but not the least, बट इसको हम इम्प्रूव कर सकते हैं, हेल्थ केयर वर्कर रिलेटेड. सो उसमें तो सबसे पहले वही आता है, वेदर एसेप्सिस कंडीशंस में इसका पूरा प्रोसीजरल एक्टिविटी हुआ था कि नहीं हुआ था. पुअर हैंड हाइजीन, मतलब आपने हैंड हाइजीन करा ही नहीं है, और it was an untrained staff who has actually inserted the central line, so which is again a very very dangerous situation, and it is difficult when you're putting up a you are doing an invasive procedure and आप किसी first year या किसी internee को भेज दें और कह दें कि आप बेटा central line डाल दो, which is practically not possible in a good hospital practices. So you have patient related, the immunodeficiency components or the immune component of the patient, device related, starting from the composition, the thrombogenicity, the flexibility, how the biofilm formation is very very easy in catheters. So कैथेटर का टाइप क्या है, उसके ल्यूमेंस कितने हैं और कितनी देर तक रखा हुआ था, हाउ मच वाज द फ्रीक्वेंसी यू आर चेंजिंग इट, and if you have kept almost for 2 weeks, that is practically surely giving a rise for the patient to go for central line associated bloodstream infection. And lastly healthcare worker, untrained अगर किसी वर्कर healthcare worker ने डाला है, poor hand hygiene practices है, और अदर रूट कॉज एनालिसिस अगर करेंगे, अगर एसेप्टिक प्रिकॉशंस के साथ नहीं अगर आपने सेंट्रल लाइन डाला है, सो यू माइट लीड इनटू सेंट्रल लाइन एसोसिएटेड ब्लडस्ट्रीम इन्फेक्शन. So what are the commonest organism which causes this? So mostly gram positive organisms, Staphylococcus aureus, which causes almost 40% of your epilepsy, and any nightmare to a physician, to a intensivist. Oh my god madam, MRSA aa gaya, now what do we go for it? Are we going to start? Because the unfortunate part, just like MDR Klebsiella, MRSA agar hai, so you hardly have the modalities left with you. Are you going to give deptomycin, or are you going to give linezolid or vancomycin? So what about in cases where we have visa also, vancomycin intermediate sensitive staph aureus, or if it is VRSA. So many places in laboratories we have challenges to diagnose VRSA also, and how exactly you are diagnosing VRSA, that is another big question. So that comes completely a microbiological part, but ये बहुत बड़ा challenge रहता है किसी भी intensivist को MRSA choose करने के लिए. So then the other commonest organisms are gram-negative bacteria like non-fermenters, Pseudomonas aeruginosa, Burkholderia cepacia, Burkholderia pseudomallei, very commonest nosocomial infection. Xenotrophomonas maltophilia. So belonging to the Pseudomonaceae family, it is havocing. Then the other organisms from the Enterobacteriaceae family like E. coli, Klebsiella. Again, Klebsi with MDR Klebsiella. It becomes a challenge for intensive, how to choose, what to choose, and some patients belong to poor socioeconomic status, those who are not affordable to take up for the higher antibiotics. So it really becomes a challenge for the hospital and for the intensivist what drugs to give. Pathogenesis की अगर हम बात करें, as I said, how many lumens are there, what is the quality of the catheter, अगर कोई cheap quality का है, अगर the catheter की quality is not good, so any foreign body reaction अगर हो रहा है, so immediately a biofilm formation, colonization हो गया, immediately patient will lead up into sepsis, thrombophlebitis, and you have n number of parameters, n number of signs and symptoms leading for the patient to lead into CRBSI. I have already stated you, never ever go for a single or only blood. It should be always paired blood culture samples to be sent. अगर आपके हॉस्पिटल में प्रैक्टिसेस नहीं हो रही हैं, प्लीज इंश्योर करें paired blood culture भेजा जाए. First and the foremost, the rule remains the same, just like catheter, urinary tract catheter, just like एंडोट्रेकियल इंट्यूबेशन जब हो रहा है, आपने बेसलाइन कल्चर भेजा है, यहाँ पे भी आपको बेसलाइन कल्चर भेजना जरूरी है. I know the burden becomes a bit high. You're sending in automated blood cultures, it will be expensive, but to raise an issue, but to improvise the practices, you have to have baseline cultures here also, so that you are easily able to diagnose whether it is actually a hospital acquired, a healthcare associated one, or the patient from, sometimes in my hospital, patient come from civil hospitals, from government hospitals, from quacks, misabled or handled from the remote areas. We don't know what all antibiotics and how they have handled it. So already baseline पे अगर positive आ रहा है, so we have to treat on those lines. But if it is coming as a hospital acquired or a healthcare associated one, we have to look into some other parameter. And one word about it, the catheter tip culture. कई बारी आपके पास आता है, and I think 90% of the hospitals around the country, even in urinary catheter, even in endotracheal secretions, they try to send उसकी tip culture भेज देते हैं. And same goes in central line का अगर remove भी करना है तो उसका catheter का tip भेजते हैं. It should be strongly condemned, and it should be strongly contraindicated. No sir, we are not collecting catheter tips, whether it is urinary catheter, whether it is central line, whether it is ventricule की आपने endotracheal secretions की आपने अगर tip भेजी है तो. No, you are not supposed to collect catheter tip culture. It should be strongly stopped. Right? One word I have to point here also, differential time to positivity. I have an intensivist who is always back of us saying that, madam, what is DTP? And please आप ये बताएंगे हमें. First of all, this is a Bactec 9120. We have 40x भी अब तो आ चुके हुए हैं. And different type of bottles we have. We have normally for the aerobic cultures, when we have for anaerobic cultures, like this one, if at all you can identify. This is for aerobic cultures. One is in green color. I think it's not here. This is for pediatric age group. This is for aerobic. This one is for anaerobic. And myco is nothing for fungal cultures के लिए भी we have automated blood culture bottles. You're putting up in automated blood culture system. This point is important. When is the sample collected? Like the patient is in ICU. You have collected it at 10 a.m. Right. Arrival to my lab is somewhere between 10 or 10:15. We try to do it as soon as possible with the barcoding, and the name of the requisition slip is also already placed there. Back of this blood culture bottle only, we put up a requisition slip where the name, identification of the patient is written. Entry into the back. Let's say 10:10, I have received it at my lab, and within 10:15, we have entered the bottle into backpack by or chasing the barcode and the requisition slip. And what time it has given the sign positive. 10 बजे आपने sample collect करा था, and if the patient is in severe sepsis, I'm so sure it would have given the clinician indication that by somewhere at 3 p.m. or 4 p.m. because for a gram positive organism the generation time is just 30 minutes, and for gram negative it is 15 minutes. So how frequently it will multiply, and immediately after 3 or 4 hours we are getting the positive sign very quickly अपने को मिल जाता है. Immediately at this point of time only, when your plate has come positive, you don't have to wait it कि कल हम इसको कल के दिन इसको सब कल्चर करेंगे. No, immediately you have to put it for identification and AST. And the best method is either you go for the direct antibiotic sensitivity, or you can subculture the plate and then you can go for AST after you have the organism which has been isolated. So आपने जो ट्रांसपोर्ट का आपका टाइम है और टाइम टू जो आपकी पॉजिटिविटी है, इन चीजों का आपको बहुत ध्यान रखना जरूरी है. From the collection time to the time you have reported, let's say it's a MDR Klebsiella, what time the next day you have reported, that is the complete time to reporting आपका पता होना जरूरी है. And differential time to positivity आपका जब flag हुआ से लेके तब तक आप कर रहे हैं, उसके जब आपने सैंपल लिया और उसमें से कितने टाइम में आपका जो पॉजिटिव आ रहा है, that becomes your DTP, differential time to positivity. Many a times clinicians they ask, intensivist out here with me is very particular about all these things. So like other bundle checklists, just like endotracheal and for your for the catheter associated, we have central line blood checklist also. This is how it looks like. Central line procedure. Again, the whole data, who has inserted, who has supervised it, किसने assist करा है, whether the all precautionary measures were taken or not, all the asepsis barrier methods were taken or not. Unnecessary line अगर कभी भी है उसको remove कर दिया जाए. Hand hygiene practices, whenever you are manipulating the central line, please make sure you are following the 5 moments of hand hygiene. Chlorhexidine skin antiseptic things are used, and avoid femoral lines. Very common. This is one of the practices. Somewhere in UK it has been taken the photograph. Central line maintenance checklist आपकी होनी चाहिए. How frequently you are doing the things. These are one critical points I have to say, that how to prevent catheter related infections. Quality assurance and continuous education. As I said, पहली बात तो कोई trained बंदा इसको insert करे, whether it is catheter associated, whether आप सेंट्रल लाइन डाल रहे हैं, वेदर आप इंट्यूबेट कर रहे हैं पेशेंट को, प्लीज मेक श्योर trained personnel is doing it, and how frequently you are educating, how frequently you are training. Continuous training procedures have to go on. Quality is an ongoing process. There are no deadlines, there are no finishing lines for quality. So every time you do, I think the second time you will say, okay, I'll improve in this way. Just that how we go for a class in a medical college. Every time we go for a class, we try and improve our presentation so that maybe, you know, next time we are presenting it much better. If you have a zeal of improving, I think your team will do it. A subclavian site instead of a jugular or a femoral site, please prefer that when it is coming to a central line. Hand hygiene, hand hygiene, hand hygiene. I think I've said enough of it. And changing administration sets at appropriate intervals. This is also very important. Remove catheters after intended use. When it is not required, I think we can go for it. And if there is any organism in the baseline cultures only, I think of changing, or after 48 hours, 48 hours, agar patient infect ho raha, please change the central line. Chlorhexidine containing cutaneous antiseptics and the dressing tapes, polyurethane tapes, they should be adhered and used in a proper way. ये नहीं कि उस टेप को आपने 10 दिन पहले लगाया था, वो वैसे का वैसे ही पड़ा. You have not, daily changing of the dressing is very, very mandatory. Okay, so this is one central line bloodstream infection event form. Just like the other forms, you have the IDs, you have the patient name, what type of event was, किसने किया procedure, what is the date of event, who did it, what is the initial diagnosis, whether any signs and symptoms after placing the central line it is there, laboratory organism, if any organisms, again common commensal for more than 2 blood cultures. Think about it. Yes, यहाँ पे मुझे एक चीज पॉइंट करनी पड़ेगी. There are people who ask us saying that कि madam, what about Staphylococcus epidermidis, coagulase negative Staphylococcus? Why? Why? Because it is maximum times either from a hand hygiene barrier से आया है, या doing any technical procedures. It can be a commensal also. So do we have to follow it? In that case, sir and madams, please look for हमारे को क्लिनिकल हिस्ट्री पेशेंट की लेनी बहुत ज्यादा जरूरी है. समटाइम्स पेशेंट हु इज बिन ऑन, किसी की स्टेंटिंग हुई है या कोई प्रोसीजरल एक्टिविटी फ्रॉम द कार्डिक एरिया अगर हुआ है, सम फॉरेन बॉडी हैज बीन इंसर्टेड, प्लीज थिंक और प्लीज गैदर द क्लिनिकल हिस्ट्री ऑफ द पेशेंट, सो दैट बिकॉज इट इज वेरी कॉमन इन स्टैफ एपिडर्मिडिस, इज वेरी वेरी कॉमन इन पेशेंट विद स्टेंट्स. Then lastly, we have the surgical site infection. I think I'm running short of time. So very quickly, I'll talk about the surgical site infection. We have the superficial, we have the deep, and we have the organ space surgical site infections. So यहाँ पे आपको दो चीजें याद रखनी बहुत ज्यादा जरूरी है. Superficial incisional surgical site infections, ये वर्ड आता है, अभी तक आप बात कर रहे थे जो भी हो रहा है 48 आवर्स के अंदर हो रहा है. So this is an infection which occurs within 30 days of the surgery and involves only the skin and the subcutaneous tissue. Superficial के नाम से आपको समझ में आ रहा होगा. And at least one of the following criteria, which is a purulent discharge, fever or the sepsis, or any pain or tenderness, or, and the most important, laboratory confirmation with the presence of organism is considered as superficial incisional surgical site infection. So what is not considered as surgical site infection, or we don't report at SSI, it is a stitch abscess. इसको हम SSI नहीं मानेंगे. Infection of an episiotomy or a newborn circumcision site, no, this is again not a SSI. An infected burn wound doesn't come under SSI. There are people from the burns ward, they come कि इसको surgical site declare करना है इसको. No madam, no sir, it is not considered as a surgical site infection. So only one, the infection which is occurring after within 30 days, 1 to 30 days के बीच में surgery के बाद अगर ये skin और subcutaneous tissue को infect कर रहा है, there is a discharge, there is fever or any signs and symptoms, or there is organism in from the pus which has been isolated, कोई organism grow कर रहा है, so consider it as superficial incisional surgical site infection. Moving on, we have the deep incisional. Again, word से पता लग जाएगा, involves the deep soft tissue, but the time duration here is beyond 30 days also. So any infection which occurs within 30 to 90 days, एक महीने से लेके 3 महीने तक, अगर सर्जरी के बाद पेशेंट के deep soft tissues, which is the facial or the muscle layers, are involved, think about it can be deep incisional. Along with that, patient का culture from the pus sample अगर आप ले रहे हैं वो positive आना चाहिए, और any pain or any signs and symptoms, pain or tenderness, fever, leukocytosis अगर हो रहा है, think about it is deep incisional surgical site infection. Moving on, next we have the organ space. Again, infection organ या space muscles को organs को अगर infect कर रहे हैं 1 month से लेके 3 months तक 1 day से लेके 90 days तक, अगर after the surgery patient is having any infection, any pus is oozing out, culture is positive from the drain system, from the open drain, from the T-tube drain, pain of tenderness, pain or tenderness, any leukocytosis, fever is pre-existing, think about patient is going into surgical site infection. What are the commonest risk factor? All these comorbid conditions like excessive use of steroid, patient is diabetic, patient बच्चों में pediatric surgeries में very common malnourished patient, prolonged hospital stay or pre-op nasal colonization with Staph aureus. As I said that किसी भी intensivist या किसी भी surgeon का nightmare होता है MRSA. This is a very cute picture we have always shared with our participants. Right to hospital. So once a MRSA, as I said, surgeon's nightmare. हमारे पास MRSA का वार्ड भी क्रिएट हो जाएगा, क्लिनिक भी हो जाएगा, यूनिट भी हो जाएगा, डिपार्टमेंट ऑफ MRSA. व्हाई? बिकॉज इफ नॉट MRSA ट्रीटेड, अगर इसका रूट कॉज एनालिसिस आपने नहीं निकाला तो आपके बाकी पेशेंट्स हेल्थ केयर एसोसिएटेड इन्फेक्शन जरूर लेके जाएंगे. पेशेंट आया किसी निमोनाइटिस को ट्रीट होने के लिए था, पेशेंट आया किसी और डिजीज के साथ था, बट आप अगर बैरियर नर्सिंग नहीं कर रहे हैं, अगर इसके एक MRSA पेशेंट को अगर आपने आइसोलेट नहीं किया है, प्रिकॉशंस नहीं लिए हैं उसकी ठीक होने में, it can infect the other adjoining patients also. So prefer MRSA patient should go for an isolation precaution, or even for that matter अगर कोई multi drug resistant organism आ रहा है किसी patient में, think about isolating the patient so that the other patients adjoining to it are not infected. And the most important part, hand hygiene of your nurses, of your healthcare staff is very, very important so that they don't infect the other patients. So the commonest organisms which lead to surgical site infections are the commonest, as I said, gram-positive organism, methicillin-resistant Staph aureus. Then we have enterococcus, and the other gram-negatives like Escherichia coli, non-fermenters like Pseudomonas aeruginosa, Enterobacter proteus. They're the common ones which causes surgical site infections. This is one proforma for surgical site infections. Again, you have the patient identification. When is the date? When do you identify the event? So any patient who has been discharged from the hospital after 5th day, there has been some stitch line, let's say hernia or lap chole has been done. After that, the patient, after 6th or 7th day of the discharge, he or she is coming with some discharge. He or she is having fever, pain. आपने WBC काउंट करवाया, वो complete blood picture अगर आपने देखी तो WBC count is increased and there is oozing of purulent discharge. Think about, yes, it can be. So how do you trace surgical site infections? बाकी patients को 48 hours के बाद आप particular areas में से pick up कर लोगे कि इसे catheter लगा हुआ है. After 48 hours fever और pain develop हुआ है, तो think about it is COTI or VAP or central line. But SSI को trace अगर आपने करना है, please make sure, ensure that in your dressing rooms, there are particular dressing rooms which are generally near the emergencies of many hospitals. At that area, you have a designated nurse who can have a history of the patient when the patient was operated, and within 30 days of the operation, only patient is having any discharge or any signs and symptoms. So think about noting it, immediately send the sample to microbiology lab. And if the culture is positive, I think you should track the patient and ask for the details. And then that's how you can look for surgical site infection, because many a times you're not able to pick it up. And that is why 4.1 to 11 is the surgical site infections over the world. That is CDC, NHSN standards. But in India, the rates are just 0.5% because less of documentation. ये सबसे बड़ा glitch रहता है हमारे लिए. And then you are filling up the form, whether it is surgical, superficial, whether it is deep, whether it is organ space, उसके बारे में आप diagnose कर लेंगे. These are some SSI surveillance pointers. अगर हम बात करें, so you have to fill up the record. कौन सी baseline culture इसका आपने भेजा था? अब यहाँ पे आप baseline culture कैसे भेजेंगे? If the patient is coming with you on the 5th day, उस discharge में अगर कुछ नहीं आया, but the 25th day पे अगर patient आ रहा है, उसमें तब आ गया. Think about from somewhere the infection has risen up. Moving on to the standard precautions. अब हम अगर hand hygiene की बात करें, what are the 5 moments of hand hygiene? I think by now the world knows about it. before touching the patient, after contact with any blood or body fluid of the patient, performing any aseptic precaution task, after touching the patient, and after cleaning the complete surrounding of the patient, we generally consider it. And last but not the least, बहुत कॉमन एज आई से कि बहुत उससे हमें कहा जाता है कि क्या है, हाथ धोना ही तो है, हाथ धोना तो हमें आता है, बट सॉरी सर, हाथ धोना भी आप लोग नहीं सीखते अच्छे से. सो वी जनरली गो फॉर इट saying that, 1 second, okay, if everybody can see me, so हाथ धोना अगर इतना आसान होता तो people wouldn't have had such many complaints with us. So with me, all of you, wherever you are sitting, if you all can perform the 6 steps of hand hygiene, there have been talking about the 7th step also, that is as per WHO, but NABH 5th standard talks only about 6 steps of hand hygiene. So if everybody along with me can do this 6 steps of hand hygiene, first of all, closing the tap, opening the tap, cleaning it with the towel, it is not the steps of hand hygiene. 6 steps of hand hygiene is nothing but, first of all, you have taken the water and the hand wash, whatever you're taking. So forming a lather, that is palm to palm, that is the first step. Again, I am saying opening and closing the tap is not the step of hand hygiene. So forming a lather, then applying soap over the back of one palm over the other. Third one is interlacing. Fourth one is closing and making a fist on the fingers. Fifth one is the anatomical snuff box or the thumb area. And sixth is press the fingertips into the palm of each hand. अब मैं आपको ये बताना जरूरी समझूंगी कि why the 6 steps are there. तो first one, आपने पहले इसका ladder form होना जरूरी है, इसलिए ये first step बनाया गया है. Second one is generally if you take up, you have the screens with you now, you have the UV rays that scanning आजकल materials आए हुए हैं. अगर आपने one hand over the dorsum of the other अगर आपने नहीं किया तो ये वाले areas generally आपके unclean रह जाते थे, इसीलिए second step बनाया गया. Third one is your interlacing, interdigital spaces. These areas generally used to be unclean. That is why this step has been introduced. Fourth one is cleaning your fingers and the knuckle area. So इसलिए ये आपका fourth step बनाया गया है, right? Then the fifth one is your anatomical snuff box area. Generally in your normal hand hygiene area, this area is generally closed. So उन areas के लिए आपके लिए काफी problem आ सकता है, इसीलिए आपका ये fifth step of hand hygiene, cleaning the anatomical snuff box area है. Lastly, making a fist on your fingertips, you're cleaning over the creases of the palm of the other hand. So you have 1, 2, 3, 4, 5, and 6. This is your 6 steps of hand hygiene which you need to follow, which is very, very important for you to know this. And with that, almost I finished with my presentation on.
First, we'll start with my presentation, hospital infection control, in this workshop with cleaning and disinfection protocol. The purpose of this cleaning and disinfection protocols are that to ensure proper evidence-based practices for cleaning and disinfection for patient care equipments and areas. And the responsibility is not just what we see in hospital infection control workshop, is that whatever is done either is done by staff nurse is responsible, or infection control officer is responsible, or infection control nurse. The cleaning disinfection protocols are asked for. It is only not the housekeeping, but everybody. So doctors play a very important role. We will see how in critical care units, I'll quote a few of the examples. In critical care units, these are the important factors when we come across. So coming to that, first is what are the contents we will be seeing in this. Classification of patient care equipments. So what are how we classify? So in the patient care equipments, what are the methods of cleaning and disinfection of the equipments, cleaning of patient care area. So all these are important when we talk of infection control workshop. No infection control program is complete if we don't talk about cleaning and disinfection, because the normal flora, the resident flora, or the transient flora, which is there in the hospital setup, that needs to be cleaned by these methods only. So all this will consist of equipments, their patient care area, and what are the methods we will be dealing with. The cleaning practice are what we have seen in our hospital setups. This is my personal experience from my hospital, that cleaning practices are often suboptimal. So what we did a surveillance culture where we find daily cleaning of surfaces near patients is often performed very poorly. The overbed tables before cleaning. This is the colony count, which you see here on a blood agar plate. There are different types of colonies. They may be gram-negative colonies, especially class Staphylococcus we mostly obtain, and certain, this is an overbed table after cleaning. So you see, before table and after cleaning, the tables were almost the amount of quantity we have discovered after the cleaning. And terminal cleaning of rooms after patient discharge is often inadequate. We'll find most of the papers which say that the cleaning, 47% surfaces targeted for terminal cleaning has been cleaned, but that means 47 means the remaining 53 are not clean. So they are the responsible force of hospital infection control. No, sorry, for hospital acquired infection, that I must emphasize here. And VRE on call buttons after cleaning. This is what we obtained in one of the surveillance cultures. We had an outbreak of vancomycin resistant enterococcus in a ward. One of the whole of the floor was infected with vancomycin resistant enterococcus, and what we obtained was the call buttons which had this. So some nurse was responsible in that case for vancomycin resistant enterococcus. So cleaning is emphasized for any infection control program. The contaminated surfaces can contribute to transmission of infections. That is what we call these days high touch infection points, we call them. And the call button is one of them. The bed rails is one of them. Then the IV stands, the patient, wherever the doors and knobs, they are the other factors which contribute to the infection. And whenever we talk about cleaning and disinfection protocols for hospital infection control, we should always remember what are the contaminated surfaces people frequently come along, and we will also be contaminated environmental surfaces which will be contributing to transmission of pathogens. So not just the hospital staff.
Dr. Suchitra, some participants, they are writing slides are not moving.
Okay.
You can see only this slide, first slide, purpose and responsibility.
Okay. Let me do it again. Okay. I'll close it and then again start it, maybe.
Okay. And now, Suchitra, we can see full screen.
Okay. This is the first slide.
Slide is also moving.
Okay, great, sir. Okay. So shall I start from the first slide again? If the participants
if you are
already
completing, you can quickly change the slides.
Yeah. Okay. Purpose. So we have discussed the purpose. What is the purpose of cleaning and disinfection protocol? Then the responsibilities on which the whole of the hospital program, doctors, staff nurse, housekeeping staff, and general duty assistants are responsible. Then we see, I think there is a problem here of connectivity. सर कुछ प्रॉब्लम है कनेक्टिविटी I think Tripti has my slides. Can she share with her?
If you can send this slide to us, we can share it from our end. I think you have already shared these slides with us.
I've shared my slides with you.
Now it's moving, ma'am. I think yes.
About the connectivity, I think.
Let me check.
So contents of, I will keep moving if it is okay.
Yes, now it is the slide showing contents of topics.
Yeah. Classification of patient care equipments, methods of cleaning and disinfection equipments, cleaning of patient care area. So these are the three things we will be emphasizing when we are talking about cleaning and disinfection protocol. Cleaning practices we will be seeing are often suboptimal. That is what we were talking about. Daily cleaning of surfaces near patient is often performed poorly. So overhead table before cleaning and after cleaning, they were almost the same colony count. Terminal cleaning of room after patient discharge is inadequate. It was only found that 47% of surfaces are targeted with terminal cleaning has been cleaned. VRE on call button after cleaning. This is we have found in most of the cases. Now, these contaminated surfaces, they contribute to the transmission. Contaminated environmental surfaces, they can contribute to the transmission of pathogens. This cannot be more emphasized, as this is the source of infection from which the healthcare workers will contaminate their hands or gloves. So what they do is, just to quote you some example, when they wear gloves, the healthcare workers, they might forget that they are touching the high touch points. And in between, if they don't emphasize, if they don't do hand hygiene, they will be transmitting from one person to another or one surface to another if they don't do hand hygiene. So this is what it simply means, that by serving as a source which healthcare workers contaminated their hands or gloves. So environmental surfaces, they get contaminated by the patient flora, or and the patient flora is pathogenic in most of the cases, since the patients are suffering from one or the other infections. And when this infection, they can be passed on hands or gloves of the patient. Then contaminated medical equipments that come into direct contact with the patient can serve as source of infection. The other source of infection from the environmental surfaces, jahan pe patient reh raha hai. So patient is suppose lying on a bed. So bed rails, as I said, the call buttons, I said, the IV stand, we said, then maybe bathroom knobs, we are saying. So they are the environmental surfaces which are the potent sources of infection. Then the other potent source of infection is contaminated medical equipment that comes in direct contact when the patient is served. So suppose a case of bronchoscopy or an endoscopy is done. So when a bronchoscope, it goes directly into the mucous surface of the membrane, and after the bronchoscopy, it needs to be cleaned properly by certain agents which will kill all the pathogenic organisms. So the agent for bronchoscopy, we say 2% the Cidex solution or a OPA solution is required for killing all the bacteria. So that medical equipment is bronchoscope. It has come in direct contact of the patient, and if without proper cleaning and disinfection, if we use this bronchoscope for the other or for the other patient, it will become a source of infection for that patient. So it needs to be cleaned properly. Then contaminated surface, they contribute to the transmission. Patients admitted to a room formerly occupied if a patient was vancomycin resistant enterococcus, or a patient of methicillin resistant staph aureus is there, or maybe a multi-drug resistant pathogen. Say most of the cases we will find these days carbapenem resistant enterococci in hospital setup, especially if we talk about critical care unit or we are talking about IPD wards. It's not for the OPD rooms we are talking about. They are at increased risk of acquiring the organism, suggesting that a terminal cleaning of room was inadequate. In those cases, if the patient has suffered from any of these transmissible contagious diseases which can be passed on from one patient to another, terminal cleaning of room has to be proper in this case. If it is inadequate, it will be transferred to other patients. Then patient may acquire organisms directly from these contaminated surfaces or from healthcare workers who's contaminated their hands in the room. So suppose there's a nurse who was taking care of a patient of a VRE or MRSA or MDR in that room. And suppose she doesn't change her gloves or she doesn't perform hand hygiene and touches the patient whenever that patient moves out of that room. So she might give these kind of infections of VRE, MRSA or MDR to the other patients itself. This is what we are trying to tell you. Then there are other things which are important. These are the high touch points I was talking about. So this is a patient bed just for the purpose. This is a pillow. This is bed. These are the equipments. These are the most potent sources of infection. We call it the ventilator screening, the IVs, these monitors where the healthcare workers might touch these surfaces again and again to set the settings. Then these are the pumps, and this is another patient's bed. So if there is an inadequate space between the bed, then also the transmission of infection is very high in those cases. This is what we are talking about. So when we talk about the cleaning and disinfection protocols of medical devices, we need to identify the 3 categories, which are the categories given by CDC guidelines also, and it comes under Spalding classification of medical diseases. 3 types of items are most important. These are critical items, that is surgical instruments or implants. Then there are semi-critical items. These are endoscopes, endotracheal tubes, and other similar items. Then the third, which is very important, is your non-critical items. So critical items are those items which goes directly into the peritoneal cavity or touches the sterile areas of the patient. So surgical instruments, they all come under critical care items and implants, and they need to be cleaned and disinfected by autoclaves most of the time. Then semi-critical items, these are endoscopes, endotracheal tubes, and other similar items like this will come directly in contact with the mucous surface of the patients. So they are defined as semi-critical items. They have to go under high level of disinfection, or they may also go under sterilization techniques. Then there are non-critical items. Non-critical items are usually those items which comes on the patient's skin areas. So the methods of sterilization and disinfection, if we talk about, the common methods are heat sterilization. Now, heat sterilization, it may be by steam methods or in hot air open. So steam sterilization, we do it by autoclave techniques. For autoclave, the sterilization needs to be at 121 degrees centigrade for 20 minutes, for 15 Pascal unit for 15 minutes. But if it is a full sterilization, say in dirty things we need to do now under biomedical waste management, we have to sterilize all our laboratory waste. Now that has a different temperature. It comes into 160 degrees centigrade for a period of 90 minutes. That is what is required. Then we can also use heat sterilization for hot air oven techniques. Hot air oven has to be, again, a dry heat sterilization method where most of the time the instruments which are glass material, they are sterilized by heat sterilization method. The second method, the other methods of sterilization and disinfection is ethylene dioxide gas. Now this ethylene dioxide gas, it is usually, we call it in short, ETOs. Now ETOs are those material in which we use gas for usually plastic materials. So these are the recyclable material, we call them, or instruments which can be again and again cycled under ETO technique. So sometimes recycling is important. So we can do those instruments by ETO technique. Then there are glutaldehyde based formulations. So like Sidex, when I talk about Sidex is one solution which has glutaldehyde, then one is which is OPA, orthoparaphenyldehyde, that is glutaldehyde, which has 2%. These can be used for high level disinfections, these are called, and they're usually used for disinfecting our bronchoscopes and endoscopes. So this is for semi-critical items. The first heat sterilization method was the critical items when we talk about. Then ETO is also for critical items and sometimes for semi-critical items, but it's only for the critical items we use. Glutaldehyde based formulations we use for semi-critical items. Now coming to the fourth technique, which is called as wet pasteurization, or 70 degrees Celsius for 30 minutes. This we all know, milk pasteurization, that is important. We now there is the whole world knows about pasteurization method. The world is drinking that milk, which is a wet pasteurization method. Then 70% isopropyl alcohol. Now this is used for your non-critical items like thermometers, they can be, or the surface of stethoscopes on which the skin surfaces of patients are touched, not much comes into use. One important thing I must say, laryngeal blade are usually 70% isopropyl alcohol. They are cleaned by 70% isopropyl alcohol. Then comes the agents like 1% sodium hypochlorite. Now this is one of the cheapest I would say disinfectant available in the market, and it is the most effective one for all spill management. I'll tell you, the sodium hypochlorite solution, all the surfaces like cleaning of wards, your wards, your critical care units, they are all the floors especially, they are cleaned by sodium hypochlorite solution. Now the sodium hypochlorite solution, they need to be made, usually a 10% sodium hydrochloride solution, readily available bottles are available, or 7% sodium hypochloride or 5% sodium hypochlorite solution is available in the market. You have to teach your nursing supervisor or a housekeeping supervisor for the use of sodium hypochlorite solution. Now, how do you make that hypochlorite? Suppose a 10% sodium hypochlorite solution is there. You ask 100 ml of sodium chloride to be mixed with 900 ml of water to make a 1% sodium hypochlorite solution. And this is usually used for cleaning of all the surfaces. In my hospital, what I do is I train my infection control nurse first for sodium, how to use sodium hypochlorite solution. Now these trainings are further given to the housekeeping supervisors. They are trained how to make a sodium hypochlorite solution. Then those they become the master trainers, and then they train the housekeeping staff. For every sodium hypochlorite solution, it has got an efficacy of only 4 hours. So after 4 hours, this needs to be changed again. Otherwise, it becomes not fit for use, or we say they have to discard after 4 hours of, because that is where the hypochlorous solution which is used will be disintegrated form, and this will be of no use or for cleaning the floors or disinfection of floors, we call it. And further, when the housekeeping people, they make sodium hypochlorite solution. So in every shift, this sodium hypochlorite solution is made, and they are, whenever they make it, the nursing supervisor usually countersigned in every shift that the sodium hypochlorite solution was freshly prepared and then made. So this is one practical thing we will be talking about whenever we use 1% sodium hypochlorite solution for cleaning and disinfection purposes of our patient area. This is a very, very important aspect. If you're thinking of using sodium hypochlorite, a check and balance must be in place before we actually put sodium hypochlorite solution as your main ingredient for cleaning and disinfection purposes. Then there are certain phenolic germicide detergents which can be used for cleaning. Iodophore germicide detergents, they are also used, like we have seen, betadine and all. Then quaternary ammonium germicide reagents, they are usually used in cleaning the surfaces areas also. But this is compared to this, the 1% sodium hypochlorite solution is much more cheaper in your cost. It is more cost effective. So we usually use sodium hypochlorite solution. Now this table is which summarizes most of the things which I have talked in last 2 slides. There is a sterilization. What are the things which are sterilized? Then high level disinfection. What is an intermediate level disinfection? And low level disinfection. So sterilization is the items which enter tissues or vascular system or blood flow through. These are the critical items, we call it, and they need to undergo sterilization process. And the sterilization process can be a heat sterilization process or an ETO, that is ethylene oxide. Then the example of this is surgical instruments, implants, and tubing. Tubings are made up of plastics and they have to undergo ETO. But one thing to remember whenever we are using an ETO is we always mark their expiry material. Even for heat sterilization material, the expiry, they need to be marked. That it cannot happen that you sterilize today by an autoclave method and it can be used for after an year. No, whenever we have a batches of heat sterilization, we always mark them with a sticker that this is expiry material beyond which the autoclave or the heat sterilization, they will undergo disintegration, or we call them that it won't work. So for practical purposes, we usually mark them 3 months sometimes, or a month. In a high turnover cases, we mark it 1 month only. And then ETO also has a life of sterilization. So it depends on what instruments you are using, what is the temperature you are using, and according to the manufacturer's guidelines, we usually mark them. This is how they need to be used or discarded, whatever the for method is. And whenever you are using an autoclaves for our material, what we need is, what we have to do, one more thing is we have to make our indicators always used with these heat sterilization methods and ETO methods. Heat sterilization, they are bacterial indicators and they are chemical indicators which we use for the sterilization material. For every load which is put in an autoclave, it should be accompanied by a chemical indicator. A chemical indicator tells you that the proper pressure and temperature was reached before actually the heat sterilization was complete. And same way, and every in our hospital setup, we are using weekly best indicators, which is a biological indicator, which is used for using the heat sterilization is proper or not. Then the high level disinfections, the items which except dental will come in contact with mucous membrane or non-intact skin, these are classified as semi-critical items. And this has to be by Sidex OPA technique. And usually Sidex, again, they have an indicators, and you have to define that when you can use the Sidex OPA. It is a very expensive solution. So we have to define whenever we are using our endoscopes or bronchoscopes that it can be dipped for how much time it should be used and when we should be changing our Sidex. So whenever we use a bronchoscope, it needs to be cleaned with an enzyme indicator with a enzyme which will kill all the proteinaceous material, which will disintegrate the proteinaceous material over that bronchoscope. And then we dip in Sidex OPA solution for 20 minutes. And after 20 minutes, we have to wash it with distilled water, we call it, or sometimes we also use the RO water we can use, but it needs to be quality conscious, or that it does not have any bacterial growth, whatever water we are using, to flush away any Sidex solution, and then dry it properly so that it is used for the another person. So this needs to be identified, that what is the process of using a Sidex OPA solution whenever we are using it. Then intermediate level of disinfection, some semi-critical items and non-critical items both can be used for intermediate level of disinfections. And this is a isopropyl alcohol and thermometer. Again, it comes in contact of mucous membrane, so it is cleaned by isopropyl alcohol. Now, low level of disinfections, these are non-critical items which will come in contact only with the skin. Isopropyl alcohol and disinfectant, they are approved by Hospital Infection Control Committee. If they are approved, then only they can be used. That's stethoscopes, they come into categories. Then bedpans can also be cleaned. In my hospitals, we have bedpan cleaners and disinfections, which are automated way of cleaning and disinfection. Also, they have a cycle. They are first cleaned with clean water and then flushing by a material which we have provided with them for disinfection, and then it is again clean and dried, and then the bed can be used. So it is more like a dishwasher, if we can say, which has got a soap and water solution, and that can be used for cleaning of bedpans also. So this is what we do. Then in non-critical patient care equipment, disinfectant with accepted disinfectant using concentration and contact time recommended by manufacturer is important. So that is what is important when I was talking about even for patients for cleaning of floors, the disinfection which is used is hypochlorite solution, for which 20 minutes is important. So these are all defined by the manufacturer. But if you are talking about non-critical devices, the contact should be more than 1 minute. It doesn't, if it is less than the recommended concentration or contact time by manufacturer, the effectiveness of any cleaning and disinfection will be beaten. So we have to be very, very careful whenever we are cleaning and disinfecting, that they are properly, the contact time is appropriate, whatever disinfection or method we are applying. Then any disinfect non-critical patient care devices when visibly soiled on a regular basis. So this is an important catch here. That is why I said cleaning enzyme is used. Suppose a bronchoscope goes into the patient mucus, and the material it is, whenever we take out that bronchoscope, it is usually soiled by saliva or maybe some biopsies taken through the bronchoscope. So this will have certain amount of protein. And if it is dipped directly into a Cidex solution and properly cleaning has not, so that Cidex solution now will have a proteinaceous material which will decrease the efficacy of your Cidex solution. So it has to be first cleaned of any organic material over the surface, or we call it any mucus particle, maybe a blood also, or a protein or a saliva, then only it should be dipped in particular solution for a particular time. So in this case, I'm talking about a bronchoscope. So bronchoscope first, clean by cleaning enzyme, visible soil, जो visible soil था, जब visible blood या protein material था वो हट जाए, उसके बाद we dip it in a Cidex solution for 20 minutes. So that is the contact time given by the manufacturer's line. It has not, if you are using an OPA, it can be decreased for 10 minutes interval also. So again, for Cidex it's 20 minutes, for OPA it is 10 minutes. This is the manufacturer's guidelines, and then it can be once you can use it for the other patient. Dedicated equipment is not available. Disinfect items after using on a patient who is isolated due to resistant organisms. So if a dedicated equipment is not available, you also can disinfect items after using on a patient which has microorganism, but an appropriate disinfectant needs to be used whenever this is defined. Non-critical environmental surfaces, if we talk about, disinfect environmental surfaces on a regular basis when visibly soiled. You should also follow manufacturer's recommendation for use of disinfectant or products. So as I was talking about that in few cases, certain certain detergents might be detrimental for those cleaning and disinfection purposes. So if a manufacturer, so in my case, I'll share an example. Ventilator cassettes. Okay, so ventilator cassettes, they are used in the ventilator, and after every patient use, we were autoclaving those ventilator cassettes. Now, those ventilator cassettes, if they are autoclaved more than 100 times, then they need to be discarded. So once what happened, we started after we rolled our hospital infection control policy that all ventilator cassettes will be autoclaved. Now what we started seeing was the result of this was most of the ventilators which has come in particular time interval, the cassettes were being destroyed in those cases. Patient could not be used for further methods. So what happened? When we had to go to the manufacturer that, look, your product is not good, but he said our product is being used as everywhere. So when we did an RCA, what we find was that manufacturers has clearly indicated that it needs to be autoclaved only in infectious cases only. There are other methods in which your ventilator cassettes can be protected from patient to patient. Okay, so then he said that you cannot use autoclave in those cases, and then we started using HME filters, which is called as human environmental the exchange gases which we put in between the tubes, and to prevent the infection happening to the other patient. And in case of resistance organism, we were used only in those cases we were autoclaving. Like for COVID cases, we autoclaved our ventilators. We also autoclave in case of tuberculosis of infection. We also autoclave in case of CREs and MRSA. So these are the manufacturer's recommendations. If we have to use any product for disinfectant or cleaning and disinfection purpose, we should always consult our manufacturer from which these machines are they are purchased, that what are the guidelines of using the disinfectant and products. So just to quote an example, this was how we should always follow manufacturer's recommendations for use of any disinfectant or products. Then clean walls, window blinds, window curtains in patient areas when they are visibly soiled. So they need to be clean. They need to be they can't be changed after every patient leaves the room, but they need to be, whenever you are following any cleaning and disinfection protocols, you have to include them in your list, that cleaning of walls is there, the window blinds is there, and window curtains are there. Then use of appropriate disinfectant in patient areas. So if contamination by blood, body fluids is possible, then an approved disinfectant. So in case of spill management, I'll tell you how the body fluids needs to be taken care of if there is a spill. And also in contamination by multi-drug resistant organism is possible. So we cannot use, suppose a spill happens or a blood is there, we cannot use ethyl alcohol, or we say spirit cannot be used for cleaning that purpose. We have to use approved disinfectant, which can be a sodium hypochlorite solution also in cases of if there is any contamination by blood and body fluids. Then prepare disinfectant solution as needed or replace them with fresh solution frequently. This is what I was talking about when I was talking that sodium hypochlorite solutions, they need to be freshly prepared. And we also have to define, whenever we are defining cleaning and disinfection policy, that how often it should be changed and what is the frequency. Suppose there are 3 patients. So this is an example that replace floor mopping solution every 3 patients. So 3 patients' rooms can be cleaned. And what happens in that case? The organic material, which I have talked earlier, that might have been more, and the efficacy of that solution would have been decreased. And that is why they cannot cannot use it for the 4th patient room. So it needs to be clean or changed less than or often at 60. Or what happens if you're using that solution for more than 1 hour, you can change it. This is my protocol for critical care, but we can the efficacy remains for 4 hours. You can change do also. So you define, whenever you are defining your cleaning and disinfection policy, you have to define what is the frequency of making the solution, how often you can change the solution, after how many patients use you can change your solution. These are the defined methods which we use. Then We also decontaminate mop heads and cleaning cloths regularly to prevent this infection. So we have cleaning disinfection audits in our hospital. So in that case, what we had done is every 10 days, the mop heads, if you're using, if either it goes from it is of no use mop heads, or if it is more than for 10 days, then that mop heads needs to be replaced, and it has to be after 10 days. The other important protocol in cleaning and disinfection protocol is that you have to dry it in a sun. So for every area we have 4 or 5 mop heads, okay, which after finishing their shift, the housekeeping staff will clean the mop head, disinfect those mop heads, and dry it in a sunlight. So we have an area in a hospital where the mop heads are clean and dried. So that is a designated area. And they have room numbers, so the floors are written here. So critical care mops cannot be mixed with an IPD area mops, and the OPD areas mops cannot be mixed. So they are always by color coding mechanism we have used to so that mixing of mops does not happen. Detergent and water adequate for cleaning surfaces in non-patient areas. So administrative office, we don't usually use hypochlorite solution. We usually use just soap and water to clean those areas. So according to the area you are facing, you have to define your cleaning disinfection protocol. And soap and water is enough in those areas. So this is just again whatever I have said, that cleaning of patient area, especially if we talk about critical area, surface need to be cleaned with 1% hypochlorite solution. So all hard surface we are talking about. We are talking about floor, we are talking about the cupboards, we are talking about knobs. They are all cleaned by 1% sodium hypochlorite solution. Then electrical equipment, if we start using with hypochlorite solution, since it gets rusted, so we cannot clean our electronic equipment. So they are cleaned with basilol spray. Basilol spray is nothing but propanol along with diluted mixed up solution of propanol and glutaldehyde, which is used in very less amounts, but it will clean your equipments, and no rusting or no equipments will not be destroyed in that case. So we use disinfectant which is approved by manufacturer for using for electronic equipments. So I hope this is clear why I am emphasizing that manufacturer's guidelines are important for anything that needs to be used, and whatever material we use, it has to be approved by CDC guidelines or FDA approved agents. So mopping should be done with 1% hypochlorite in every 2 hourly. I am talking about this 2 hourly in critical care areas only. I'm not saying that in wards. So we will change the frequency for wards. The operation theaters and cath labs, they need to be cleaned using 1% sodium hypochlorite between each case. So our OT cleaning has very strict guidelines. We get 30 minutes between the patients to clean the OT, and for that 1% sodium hypochlorite wipe solutions, the biomedical waste management is removed, and which is generated during OT time, and then they are cleaned with 1% sodium hypochlorite solution, which gives us a contact time of 20 minutes so that everything is disinfected before the patient is wheeled into the OT. The OT tables are disinfected with Tuffy. Now, these are the ready-made wipes. We have it. This is just so that the Tuffy are the wipes, which has, again, the sodium hypochlorite solution in it. And this is for the ease of it, that nobody has to make a fresh solution at that time. It is a readily available wipe. We will wipe all the OT tables with this Tuffy, we call it. Thorough cleaning of OR and cath lab should be done in every weekend with 1% sodium hypochlorite. When we talk about this, that thorough cleaning, so we mean that all equipments, they are covered and we are spraying with 1% sodium hypochlorite solution when we are talking about thorough cleaning of OR and cath labs. Then comes cleaning of patient area in non-critical area. Again, surfaces, they are cleaned with hypochlorite solution, and electronic equipments if they're in that non-critical areas, along with bacillol spray, we call it. Mopping done again with every shift. So in critical areas, we were saying 2% to every 2 hourly the cleaning should be done. But in case of non-critical areas, this cleaning is done in every shift. And areas should also be cleaned with bacillol. So what we do is we spray the solution of bacillol usually after the patient leaves, and for every shift change also. Now, there are other methods which we can use for room decontamination methods. These are become more famous after the COVID invention, because UV, you must have seen during the COVID time, small gadgets or small UV light boxes were available where you could keep your items so that this is infected before you take it inside your room. So in the same methods, we have new room decontamination methods also, in which ultraviolet light system is used. And this is a very quick way of disinfectant. I must admit that automated mobile UV light suits, they use UVC, which has got a range of 254 nanometer range. What this does is can be placed in patient rooms after patient discharge and terminal cleaning has been performed. So you can wipe the surface with 1% hypochlorite solution, and if you have to disinfect the surface, terminal clean it, you can switch on this light for around 20 minutes, and all the and it all depends on how many lights you have to use and what is the area you are defining. So it should reach all corners ideally, this UV light, and they can be disinfected. So in COVID times, most of the COVID rooms were being disinfected by UV light because the staff was low, but we purchased a lot of UV light, these things which could be mobile, and after one patient was discharged COVID room, the other. So each floor had these COVID lights, peeling COVID lights, those could be used. Then significantly, what it does, it can kill vegetative bacteria and also kill spores. It also reduces bacterial counts in patients' rooms. It is easy to use and require relatively short cycle times. Now, this is the advantage of using a UV light. So not much resources required. That timing is less and less labor intensive. You just peel this UV light into the rooms and your area is terminally clean. So we can use these methods if we have to do it quickly. Then improving cleaning disinfection practices. This is an important part. Training. It is required all the time for all the members who are involved in cleaning and disinfection processes. So for that, educate housekeepers regarding recommended cleaning practices and importance of following hospital cleaning policies. You should also ensure compliances by housekeeping staff with cleaning and disinfection procedures. Now, how you do that? How do you ensure compliances by housekeeping staff in cleaning disinfection procedures? So for that, first we educate, and then infection control nurse. Every area is divided among the infection control nurse. So to share an example, we have 3 infection control nurses in our hospital setup. So the area is divided and they go on rounds each day to their particular areas, and they have a sheet of cleaning and disinfection procedure. They will have to ensure that all the areas which are covered in there have proper cleaning disinfection has been performed or not. Otherwise, after the audits, again, we escalate to their supervisors that these areas were not clean, and this is what we found in our audits. Then we educate those housekeeping staff again for proper cleaning and disinfection. So this is a continuous cyclic program. It is not a one-time cycle that you do cleaning disinfection and then you forget it. You have to keep it doing it again and again and again, so that the proper cleaning and disinfection practices are there. If proper cleaning disinfection practices are there, then only the hospital-acquired infections can be prevented. So develop policies regarding patient care equipment and environmental surfaces that are to be cleaned by housekeeping and nursing staff. So this is the important thing, that whenever we educate, we have to educate our staff regarding the cleaning and disinfection protocol, so that we are sure that the cleaning and disinfection is taking place. So that is what I have to say about cleaning and disinfection. Any questions I can take up right now? Or there are certain questions which I see on screen. So it is, ma'am, for cleaning 1% hypo or 0.1 hypo? 0.1 hypochlorite solution is not used, 1% hypochlorite solution is used. And how long you keep this UV light? 20 minutes is the recommended time for keeping UV light in the area. So before I move to another slides. So I got a question which says that how to make a 1% hypochlorite solution. The 1% hypochlorite solution is made if you're using a 10% hypochlorite solution, which comes in a can. You pour 100 ml of hypochlorite solution in 900 ml of water. This will make you 1% hypochlorite solution. This is what I have been using it for time. So this is what it is. Now I'll move to another. Just give me 5 minutes, then we'll share the. So there's another question about this is OPA mandatory for bronchoscope for cleaning or killing Mycobacterium tuberculosis? Yes, it is an important thing. OPA is mandatory because what we have seen is that Cydex solutions takes more of time, and that is why it is what we should be doing it. So can you see this slides? Sorry, we cannot provide the recording of the session. That you need to ask the organizers of this talk. So moving to the other hospital infection, but in this workshop, personal protective equipment. When we talk about personal equipments, it's a specialized clothing or equipment worn by an employee for protection against infectious material. So personal, as it says, it is for me, protection is for protection, and equipment is whatever the gears which are provided, they are for our protection only. So personal protective equipment, it is a specialized clothing or equipment worn by an employee for protection against infectious material. The PPE is a short term which we apply for personal protective equipments. It prevents contact with an infectious agent or body fluid that may contain an infectious agent by creating a barrier between potential infectious material and the healthcare workers. So this simply means that what a personal equipment is, it is an equipment which will prevent a person from infectious agent. Now, this infectious agent can be any bacteria, viruses, fungus, XYZ, COVID, no, Corona, Omicron, Delta, anything, or a body fluid that may contain an infectious agent by creating a barrier. So it will create a barrier between the potentially infectious material and a healthcare worker. So types of material with types of equipments which we can use in a healthcare setting is gloves, which is used to protect hands, we all know, gowns or aprons to protect skin or clothing, mask and respirators protect mouth, nose, respiratory tract from airborne infectious agents, goggles protect eyes, and face shields protect face, mouth, nose, and eyes. So this all when combined or anything else is known as personal protective equipment. There was a general misunderstanding, misnomer, which I should say during when जब COVID आया, तो people were like कि हमें personal protective, हमें PPE नहीं मिल रहा, PPE नहीं मिल रहा, PPE नहीं मिल रहा. Now PPE that time was a hazmat kit they were talking about, the whole thing which is taken as a body suit. So they were not available. Gloves, they were available most of the time. The masks were available. Now, I'm not talking about the first wave. First wave में तो लोगों को पता ही नहीं चला था कि क्या use करना है. And there was a lot of shortening because everybody started using in that era. I must say now it is a gone past thing. So these are gloves, gowns, aprons, masks, respirators, goggles, face shields. They are the personal protective equipments which we will be talking about. Now goggles, they surround the eye area. They give more protection in situations where you might encounter splashing liquids, fumes, vapors, powders, dust, and mist. They must indicate that they are chemical splash goggles to be worn for that purpose. So goggles, I usually recommend even before the COVID for HIV patients. And this will help in prevention of splashes, especially when it is the sensitive area like eye are considered. And the limitation of this goggles is fogging. So in case we have seen that if it is used with a respirator, the fogging happens on the on this your goggles you're wearing, and you're unable to see it, and then you have to check it again and again. This is what we have to see. Then the gloves, purpose of gloves is patient care, environmental surfaces. The material, it can be different. It can be vinyl, latex, nitrile, depending on the use. So there are these are all latex gloves. They are a little bit cheaper in variety. They are powdered usually. The nitrile gloves, they are expensive, and they are usually sterile. So it all depends what are the resources they can be available to your hospital setup or to your OPD setup for the glove material. But the purpose remains same, that it is a protective care. They can be sterile or non-sterile. When we talk about judicious use of any gloves, we need to be very, because since everything has a cost attached to it, especially when we are looking at both the sides of it, the pros and cons. So sterile gloves, they should be permitted only in which the procedures needs to be performed, like maybe in OT, maybe in critical care units, in cath labs, we can use it. For OPD purpose, we don't use any sterile gloves. We will need only non-sterile gloves. So say, if I talk about me as a microbiologist and taking care of, I'm a head of laboratory medicine in my hospital, I'm looking after the lab services. So what we give to our phlebotomists is a non-sterile glove. So you can have a judicious use of gloves. 1 or 2 pair. Why this line comes 1 or 2 pair? Because in case of COVID, double glovings were advised even by ICMR guidelines. And there were two pairs of gloves which were used, one which was used first, and then the whole PPE or the hazmat kits was worn, and then last came the pair of gloves. So when I tell you about the sequence of PPE, we will understand it more. Then single use or reusable. So single use, now reusable gloves, they are out of context usually. Single use is recommended most of the time for gloves. Now this is an important thing, do's and don'ts of gloves use. We should always be working from clean to dirty area. Okay, otherwise if we move from dirty to clean, we will dirty the clean area also. So the dictum of any glove use is always clean to dirty areas. Then limit opportunities for touch contamination. That means after we have worn gloves, we get the myth that we are protected and we can touch any surfaces. Now, this is what we need to keep in our mind whenever we are using gloves, that it protects yourself, others, and environment. But if you keep on touching the surfaces, then the purpose of gloves gets lost. So do not touch your face or adjust PPE with contaminated gloves. This is very, very important. And do not touch environmental surfaces except necessary during patient care. Because if we unnecessarily keep on touching the environmental surfaces or face or keep on adjusting, which can be a habit with many persons, but these needs to be trained or a skill need to be developed for this gloves use. I must emphasize that during education program, use of gloves should be taken into care. Then mask. Masks protect nose and mouth. It should fully cover nose, mouth, and prevent fluid penetration. Now after the COVID, I don't need to go and explain what is the importance of mask and how it should be worn. Even I must say कि बच्चे को पता है कि अभी मास्क पहनना कैसे है, उसके मास्क के यूज कैसे हैं. Okay, so it has to be fully covered nose and mouth to prevent fluid penetration. That is the most important. We had a lot of memes coming up on the WhatsApp group and other groups that how it is if you're wearing a mask below the nose, it is like exposing yourself without, like, not wearing an underwear. Excuse me for quoting that example. This was as hazardous as that if we were not covering our nose. The type of mask, there are different type of masks. Sorry for that slide, I think. The type of mask which needs to be are there. 3-ply mask, we call it, or N95 mask. They were the most important mask. The other type is now, since the COVID has decreased or the incidences of COVID has gone down, everybody is wearing a cloth mask, which is fair enough. So in a hospital setup, we were using N95 mask. N95 mask simply means that this is a filterable percentage of any material which can go through. So N95 was also recommended because the size of the fibers which was used, the coronavirus or the say RCRV virus could not penetrate that fiber. So N95 was recommended for hospital. Whereas for non-hospital things, we could use a 3-ply mask. 3-ply is the mask which this person is wearing on this picture. So it is a surgical mask, we call it, and this is recommended if you are seeing a patient from a distance of, say, 3 meters. And N95 was recommended when any procedure was being performed, which was later changed for N95. Everybody started wearing. So these are the two most important types of masks. Whenever we are using any N95 mask, one thing I must admit, there has to be a fit test involved in it. So fit test, it is that if the mask is not fitted properly over your nose and mouth area, then it is of no use, because then the organism may enter from the sides or from area which is not covered. So a fit test needs to be taken. We've had taken a lot of training when SARS virus or a COVID virus, we call it, had come, say how to test the mask in your area. So fit test needs to be performed before actually wearing any N95 or N99 type of mask also. Now, the more after we know what are the type of personal protective equipment, the more important thing is what is the sequence of donning personal protective equipment. So, gown needs to be worn first, then the mask, then the goggles and gloves. When I'm talking about this sequence, there's one thing which is missing. Then when we talk about COVID, the first pair of gloves was first use. You have to perform an hand hygiene, then wear the first pair of gloves, then again perform hand hygiene, and then your gown needs to be worn, and then a mask or a respirator needs to be fit, that is N95, then your goggles, and last comes the gloves area. So that is the cleanest area which you should be wearing. So how to don a gown? Select the appropriate type or size. That is more important because various sizes are available. A short-haired person wearing an XL size does not help in prevention of any infection, or an extra large person wearing a small size does not solve the purpose of wearing a gown. So it has to be appropriate type and size. Then there could be opening in the back or opening in the front, whatever there is. If it is opening in the back, you usually take the help of other person who is washed in your OT area, or when we were donning, then they were donning has to be in groups we were doing it. So they were able to tie each other's opening secure at neck and waist. If the gown is too small, you can use two gowns. That means one in front and one in down. So this happened really practical in our area when we were having COVID. Lot of small size gowns were available. So we had given these two type of ones. One was worn in front, another one from the back, so that the whole surfaces of the doctor was covered, and gown one to be tied in front and gown two ties in back. This we have practically done it. So there's no harm in doing it if the appropriate size and type is not available, but you have to cover the every exposed area. That is what is important to us. Then how to don a mask? Place over nose and mouth and chin. Fit flexible nose piece over nose bridge. Secure on hat with ties or elastics and edges to fit. So this is important. How to don eyes and face protection? Position goggles over eyes and secure to the head using earpieces or headband. Adjust comfortably. Then how to don gloves? Don gloves last. Select appropriate type and size. Insert hands into gloves. Extend gloves over the isolation gown gloves. So this is what is required when we are talking about the sequence of wearing your PPE. So this is the second pair of gloves, I must say, that this is how to be wear. Then when we talk about how to remove personal protective equipments, so again, the catch principle is contaminated and clean areas of personal protective equipments. Contaminated is outside front areas of PPE that have or likely to be in contact with body sites, material or environmental surfaces where the infectious organisms may reside. So you have to see that contaminated is always the outside front, and the clean area is inside, maybe a back ties or a hand and back. So areas of PPE that are likely to have been in contact with infectious organisms. So that is the contaminated area, and that is the clean area we are talking about gown. So sequence is always the first pair of gloves which first needs to be removed. Then the gown goes, then the face shield, and last to go is your mask and respirator, or the last second pair of gloves. This is how we do it. And in between everything, the gloves, the outside of the gloves are contaminated. So you take out one glove and then catch it in the same hand. And then when we are removing the second glove, you have to put your finger inside and glove it in the other glove. That is the technique we have to acquire, or have the skills needs to be built. When we are talking about down, the front of the gown and sleevelets are contaminated. So you remove it upside, inside out. Then the eye protection goes, the outside will be contaminated. So you usually take it from the back side, and respirators also. And after all these procedures, you should clean your hands with soap and water. In between, you have to clean it with the hand rub, and then last you have to clean it with soap and water. So this I was talking about, grabs outside edge near wrist, peel away from hand, turning glove inside out, then hold in opposite gloved hand. Slide ungloved finger under the wrist of the remaining glove, peel off from inside, creating a bag from both gloves, and then discard. Then for removing gown, unfasten tie, peel away gown from neck and shoulder, turn contaminated outside towards the inside, fold a roll into bundle and discard. So there's always a way of doing it. Remove gloves or face shield, grasp ear or hat pieces with ungloved hand, lift away from pores and place in designated receptacle or process. Removing a mask, untie the bottom, top, tie and remove from face and guard. Now, this is the most important step, I must say, that perform hand hygiene after removing PPI. If you don't do that, the purpose of wearing all the PPEs is usually wasted. If hands become visibly contaminated during PPE removal, wash hands before continuing to remove PPE. And then you wash hands with soap and water or use alcohol-based rub. So the sequence of wearing and donning, we call it, and when we remove it, we call it doffing. So both the techniques are important, and they is a purpose that why we are doing that. Sometimes shoe cover is also worn, so we can have this shoe cover, body gown, headgear, surgical mask, gloves, and hand gloves. An order of removing again: gloves, body gown, eye goggles, mask, headgear, and shoe cover. So shoe covers usually go last. If you're exposed to needle stick injury, then what is it? In case of exposed or injury immediately, first aid is wash off with soap and water, encourage bleeding, never squeeze, exposed mucous membrane, including conjunctiva, wash copiously with water and find out the source. So what I was saying was that whenever a needle stick injury happens, there's always a panic attack. So don't go into that panic attack. Wash off with soap and water, encourage bleeding, but don't squeeze. So that simply means you don't have to squeeze. What is the blood flow? Let it flow and keep on washing with water. Then you have to try to find out the source. Just press it once the free flow of blood stops somehow. Just press it and just ask you have to report it to your manager, maybe a nursing supervisor, whoever is senior in your dog, and you have to get your tested yourself. That is the most important thing. You should be vaccinated and you should be having testing titers. If you know the source of the person, then you need to have that positive, then take treatment and prophylaxis as per doctor's orders. If negative, then inform the patient. So what happens is, if the injury happened, how it happened. So was it accidental or was it negligence? That is what we have to see. Negligence is there. And if there's a history of hepatitis B immunization is there, then you also have to give blood tests for anti-HBs antigen, antibody, HBs antigen, antibodies, and HCV and HIV. These are the viral markers which are most important when we have to take it in a needle stick injury protocol. Then follow treatment as advised. Usually what in our hospital setup is we give advice of a gastroenterologist, because they are seeing a lot of patients of HIV, HBV, HCV. So we usually recommend to them, or internal medicine, and then complete the needle stick injury form and incident and form it to, usually we asked our victim of needle stick injury to go to ER or infection control nurse for further management of study. Then the treatment which is given is the full-time period investigation follow-ups, which we have to do is follow-up time period for needle stick injury: 0 days, then 6 weeks, 12 weeks, and 24 weeks. This is a protocol which needs to be taken into account. So what happens is, all nurses, they should be vaccinated, and all nurses, when I say especially the nurses, but all the healthcare staff should be vaccinated against hepatitis B, and record to be maintained in the department with a copy of infection control nurse. The vaccination schedule for hepatitis B given 3-dose series, dose 1 now, 2 in 1 month, 3 in approximately 5 days. And then these needs to be given intramuscularly. So 0-1-5 day, 0-1-5 month is the time interval for vaccination schedule. This needs to be followed in strict manner. Then the immunization schedule and employee category for reference, we have using this vaccination schedule in our hospital infection control policy. So as I say, this is an attached Max Healthcare policy I have attached here. The doctors, they need to be vaccinated against hepatitis, influenza. The nurses need to be vaccinated against hepatitis B, influenza, chickenpox. The microbiology staff, we ask everybody to vaccinate in hepatitis B, influenza, chicken, and typhoid, as well as meningococcal vaccine. The paramedics, especially the OT, when we talk about the cath lab technicians, they need to be vaccinated with hepatitis B and influenza. The housekeeping GDAs, the cleaning staff, they need to be vaccinated against hepatitis B and influenza vaccine. Then F&B, we have in-source kitchen where the food is prepared. So on-roll staff, they need to be vaccinated against typhoid vaccine. And the outsourced staff means those who are involved generally in other areas. We call typhoid vaccine, and the most important one, this by new guidelines have come about the tetanus toxoid. They need to be vaccinated all the time. And this is the dosage schedule for hepatitis. Quantity given is 3 doses on 0-1-6 month schedule, then influenza 1 every year, then chickenpox, we give it for 2 doses, second dose after 4 to 8 weeks. Typhoid vaccine is usually given 1 dose after every 3 years, and meningococcal vaccine is given every 1 dose every month. Then, what is the post-exposure prophylaxis for hepatitis B? When we talk about post-exposure prophylaxis, the healthcare workers who is vaccinated, the antibody titer is checked. If it is more than 10, then no additional treatment is required. But in our guidelines, this is the CDC guidelines. What we have taken is 20 international unit. Okay, if antibody titer is less than 2, मतलब जो आपका हेल्थ केयर वर्कर था वो वैक्सीनेटेड तो था पर उसका एंटीबॉडी टाइटर लेस देन 10 इंटरनेशनल यूनिट आ रहा था. अगर पेशेंट हेपेटाइटिस नेगेटिव है, ओके, देन या अननोन सोर्स होगा या हेपेटाइटिस पॉजिटिव होगा. हर केस में ना बूस्टर डोज या कंप्लीट सीरीज ऑफ वैक्सीनेशन उस हेल्थ केयर वर्कर का होना चाहिए, चाहे हेपेटाइटिस नेगेटिव हो, चाहे अननोन सोर्स हो, चाहे पॉजिटिव हो. लेकिन अगर पॉजिटिव है हेपेटाइटिस तो उसके साथ उसका बूस्टर डोज along with immunoglobulins it is necessary. Okay, so healthcare workers, antibody titers less than 10. These are the important points needs to be remembered. In case of negative, the booster dose, and now we say complete hepatitis is required. If it is hepatitis positive, along with immunoglobulins needs to be given. But अगर healthcare vaccinated ही नहीं है, पहले तो ये गलती HR की है, I would say, कि उसने बिना vaccinated staff को रख लिया. But immediate vaccination program needs to be done for that case within 7 days, along with immunoglobulins needs to be given intramuscularly. This is the most important fact we should be remembering whenever we are talking about our needle stick protocol. Then follow-up of these cases, those who are exposed to hepatitis, then antigen and antibody levels are there, then decide on appropriate prophylaxis, repeat hepatitis antigen at 3 and 6, and gastro references usually given. If it is a post-exposure prophylaxis for hepatitis, suppose मेरे को पता चल गया कि जो patient है मेरा hepatitis C positive है, उस केस में हम क्या कर सकते हैं? हमें नो एक्टिव प्रोफाइलैक्सिस या इम्यूनोग्लोबुलिन्स क्योंकि अवेलेबल ही नहीं है, हम उसको इफेक्टिवली नहीं दे सकते. इंटरफेरेंस आर आल्सो नॉट रिकमेंडेड प्रोफाइलैक्सिस. सो व्हाट वी नीड टू डू इज वी शुड टेस्ट फॉर HCV RNA, LFT, that is lipid profile, kidney profile, CBC, and these LFTs, they are repeated after every 4 weeks to check, to prevent that hepatitis, the healthcare staff is not going into hepatitis C infection due to this. Yes. So if it is positive exposed NTCP and baseline LFT, then refer consultant, and HCGP along with SGPT of exposed 4 to 6 months is taken. Now this is an important slide. Post-exposure prophylaxis for HIV. So whenever a patient of HIV is there, we should have flags, though it is not recommended by NACO guidelines that all patients need to be treated as same, and there's no special sign and signals which should be given for HIV positive patients. But actually, whenever we are taking a blood, we should always mark with a flag that this may be a potent infectious vial which needs to be taken care of, or this is a potent infectious patient is we need. So we put a tag, we put a marker, say a red flag for all HIV, maybe MRSA, VRE, so that a preventive measures can be taken. So when we talk about post-exposure prophylaxis for HIV, PP is an emergency medical response that can be used to protect post-exposure prophylaxis to protect our HIV as soon as to be given. So common side effects with post-exposure prophylaxis should always be explained whenever we are giving any post-exposure prophylaxis, which include anemia, nausea, peripheral neuropathy, neutropenia, myopathy. And this PPE program drug regime for HIV as per NACO guidelines is Viridae TAP, that is once a day oral, and for 30 days needs to be taken. Domperidone along with rabeprazole, that is just an antacid once a day before breakfast, 30 days, and Vika capsules. This is the HIV prophylaxis program we usually follow for our post-exposure prophylaxis if needs to be given. To tell you the truth, actually, the post-exposure prophylaxis is more traumatic for a patient. I remember one incident when by one of our nursing staff, she was very young and she joined just maybe a week, maybe a month before. And there was this patient who was very violent, HIV patient, positive patient who was violent, and she had to go and give injection to sedate that patient actually because he was a violent patient. So when she went, that needle, after giving the injection, that needle stick injury happened because he had shaken his leg, his hand, and she was so horrified in that. There was a lot of counseling, a lot of support was needed, but after she agreed to get that prophylaxis, more was when she suffered continuous vomiting to at least 10 to 15 days. So we have to give her leave for 30 or 40 days. We have leave we have given to that female, and then after 40-50 days, a lot of supports along with follow-up was given so that the exposure prophylaxis was to be successful. So not just prophylaxis, we also need a lot of counseling and support sometimes for our healthcare staff. Safe needle, safe lives. This is the law which we'll be talking about. So this is what exposure prophylaxis is, and this is what it needs to be taken care of. Now, when we talk about spill management system, spill management is minor and major. So minor and major spills can be categorized spill management policy, blood body fluids spillage, then there's a type of chemical spillage, then there's a biomedical spillage, and there is a cytotoxic spill. But for practical purpose, I would say minor and major spill, we call it only for body fluids. The chemical spill, the biomedical spill, the cytotoxic spills, they all come under major spill process. So in my hospital, minor spills, they are less than 30 cc. What you have to do is wear cap, gown, face mask. And usually our spill kit is kept at all nursing stations. So all that nursing stations will have this gown, cap, face mask, gloves, and a shoe cover, not gum boots actually. And you also place tissues and newspapers in that spill kit. Now, whenever a spill happens, one thing is that you have to notify the spill management team to clean the area. So there's usually a central calling area, we call it, or we give a housekeeping supervisor number in case of minor spills. And what the responsibility of the spill team is, they bring the spill kit and they place sodium hypochlorite solution, that is 1% solution. The nurse, under the supervision of nursing supervisor, you cover the area with trash can, wait for 20 minutes, wipe disposed tissue in yellow bag, and you usually fill up the incident form. Now, this is because a minor spill is there, and this can be taken care of by the nursing staff itself. So this is what it is required. You can take a help of her. So this minor spill is maintained by the in-house team, we call it, or that floor team, we can say, where the spill has taken. But suppose it is a major spill. So if it is a major spill, say a biomedical spill or a chemical spill, or somebody has vomiting or a urine has spill, or a large amount of vials which was being carried to the lab has broken. So that will cause a major spill. So a spill team will be responsible for management of spillage of biologically hazardous material. So what you do is you wear personal protective equipment, place tissue paper over the spill, and there's a special designated spill team, we call it, and they have a speed dial. So you announce, like in any emergency situation, you announce that at such number 8244, the spillage has happened, and to bring the spill kit, pours sodium chloride solution as per dilution. Nursing supervisor should supervise, again cover the area with trash can, wait for 20 minutes. Now this 20 minutes is important because this is a contact period of hypochlorite solution. Wipe and dispose the tissue in yellow bag and fill up the distant form. So usually a larger team is there who wears PPE properly, and then they come and clean the area in case of major spills. So this is the outbreak management, and this will be in context with COVID especially. So the COVID situation, we will talk about the outbreak management in this era. And the responsibility when we talk about is for prevention and control of infection in hospital lies with the infection control team. So actually, it is not the responsibility of infection control team, but the whole responsibility lies in most whoever is participating in that program. I must emphasize, but whatever said and done, this should be comprised of infection control doctor, infection control nurses, and when necessary, the chief executive or representative has to be taken into account. Then infection control advice, it should be available 24 hours a day. So if an outbreak is happening, this is what I'm talking about, and to our surprise and to all the microbiologists, the outbreak is being continuous for last 2 years, I must admit. So this is available 24 hours a day. Outbreaks of hospital infection may vary greatly in extent and severity, ranging from few cases of urinary infection to large outbreak of food poisoning involving hundreds of people to one case to diphtheria. So this is how it may vary in extent, and according to the extent, the infection, the outbreak management needs to be taken care of. There may be one person with the expertise to decide that a major outbreak is occurring. Usually it is an infection control doctor, the consultant microbiologist. He takes the lead role in identifying and managing a major outbreak of hospital infection. The most important point in this is that the recognition of an outbreak. In some outbreaks, this may be immediately obvious. For example, outbreak of Shigella or virus diarrhea, but infection occurring in patient discharged after a short hospital stay, that is childbirth, day surgery, may go unrecognized for some time. Many outbreaks, they are detected by microbiology laboratory due to increased isolation of unusual pathogens. And that is why most of the time, the microbiologists, they are taking a lead in identifying any outbreak. So laboratory must report suspicions to infection control doctor as soon as possible. So in my hospital setup, I as a microbiologist, we have a trigger mechanism. And in this trigger mechanism, we mail those triggers every day, twice a day, from our laboratory to the stakeholders. The stakeholders here are infection control nurse and the medical advisor, the medical superintendent, the nursing CNO. These are the four important people that we mail all the triggers, whatever we have isolated in labs, which may contribute to an outbreak. So say a case of Shigella is isolated in a microbiology laboratory. And so we say that such patient is lying in this particular room with a shigellosis. So outbreak to prevent that outbreak, we are giving those triggers. So that is why many outbreaks, they are first detected by microbiology laboratory due to increased isolation of unusual pathogens. The laboratory must report suspicions to infection control doctors as soon as possible. So if an outbreak exists, the infection control will make an initial assessment to determine. So if one patient has Shigella, so the infection control nurse goes to that particular patient, takes a history and assess whether the other patients are coming or the family members are also having shigellosis. Or if we have, say, 2 patients of rotavirus have been isolated, again from pediatric people or pediatric ICU, we try to identify whether they are related or unrelated. So the initial assessment will be made by infection control nurse or infection control team. So nature and size of an outbreak, if it is confined to the hospital, whether there are community implications or whether the ICT can cope with investigation and control. So this is what I'm trying to explain this point. कि घर से आया या hospital में, this is the first thing we have to understand. If an outbreak is likely of major importance. So suppose there are 5 to 6 patients having rotavirus. So this is an outbreak. So we first is to need to identify an outbreak. So what is that outbreak? Outbreak is whenever the incidence more than what we are seeing usually is identified is called as an outbreak. So we need to identify whether it is a major outbreak or an outbreak. So major outbreak control group, in case like in COVID, we had formed major outbreak control groups. So once the patient started of COVID coming to our hospital, the wards, the areas, the collection areas, the nursing staff, donning, everything need to be identified. So first of all, the first thing which will happen was major outbreak control group was formed. This meet was according to the need of acute state of outbreak. The functions of this major outbreak control group were to take all necessary steps for the provision of appropriate continuing clinical care of patients. Suppose the outpatients which came to our hospital, are they being segregated from the outbreak patients? These staffs and visitors who were coming during the outbreak. So there was a separate entry for the staff. There was a separate entry for visitors during the outbreak control. So you have to continue caring of your patients, normal patients. You also have to take control of your outbreak also. So to ensure adequate communication channels have also been established with all need to take kept informed about progress and control. So communication is a key, and that needs to be established with all ever who needs about the progress and control of any infection which is having on an outbreak infection. This includes nomination of one individual with responsibility for making statements to media throughout the duration. So what happened was during initial phase of COVID, nobody was allowed from the hospital except the medical administrator or medical superintendent to convey what were happening, what are the steps, how many patients were admitted in COVID. So this is what the adequate communication channels means. And if any information leaking from any staff member, he was under punitive condition. He had to be given the punishment, need to be given, or maybe sometimes even you can lose your job if the confidential information goes out of the, so the communication channels need to be established. Then to clarify resource implications of outbreaks and its management or how it will achieve. So additional supply of supplies like in this case of COVID, gown, masks, respirators, they need to be there. Then the staff need to be identified who will be taking care of these patients. Okay, and what will be the shift, how we will take care, all this needs to be, these are the resource implications which need to be identified. Then there was to agree and coordinate policy decision on the investigations and control of outbreak and ensure implementation. Responsibility was allotted to specific individuals with accountability for action. So that was a procedure, how we should deal with a major thing. We have to make a policy. So we have this time the COVID policy, they were coming from ICMR. So whatever the ICMR was making a policy, it needs to be framed in a manner in which our hospital can use it in a judicial manner. Then they consider for the need of outside help and expertise. So outside help was there. Then sometimes if there was no adequate rooms were available for our COVID patients, we were taking help of our sister, say hospitals or the other hospitals which we have coordinated for admissions of COVID. Then to provide clear instructions or information for ward staff and others. So written information, a lot of posters and awareness was created during the COVID time so that all ward staff was aware for whatever the information was pouring in from outside or ICMR or the government compliances to be met. Then to agree arrangements for providing information to patients. So you remember in COVID era, no attendant was allowed with the patients. So there had to be a way, a two-way system has to be created. So there was a speaker kept at the patient's bedside, or a video call facility was trying to be facilitated between the patients and the patient's relative, along with doctor also we need to be talking. The senior doctors say they were on calls, so they used to talk to the patients. To this information was given to the patients, what is the progression of the patient, and the junior doctors would go and examine the patient. So there has to be an arrangement providing for information to patients, relative and visitors. Then to meet frequently, usually daily, and review progress of an outbreak management investigation and control. Now this pertains to all the stakeholders, say the management, who had to see what is the progress of the COVID. So meetings were in written agendas, minutes and actions were to be produced. Then to define the end of outbreak and evaluate lessons learned. This was important because any outbreak which has happened, there are always learnings attached to it, and those learnings needs to be distributed or should be taken into account whenever for next wave to be prepared. Then to prepare preliminary reports within 48 hours and to inform others outside in our hospitals the lesson learned. So this was how our major outbreak control group was working to control an outbreak. So, the defined procedures. Now, who would have been the members? Who were the members of this outbreak control group? Head of the nursing, the CNO, she was a representative. Then director anesthesia, or in our case, he's our medical advisor also. So he was the chairman of infection control committee at that time. Then director emergency services was taken into account because most of the cases they were landing up in triage in a state where it needs to be controlled. Then the additional members, those who were part of this outbreak, were head of critical services, head of Department of Medicine, director lab services, the catering manager, the CSSD manager, the housekeeping manager, the hospital chief pharmacist, the supplies officers, and representative of any other department. So what we are doing is, there was a way, critical care was the most sought of unit. So he was a part of this major outbreak control. Then lab services was important because the COVID RT-PCR reports needs to be collected and then distributed and then conveyed to responsible authorities. So director of lab services was a part of major outbreak control group. Then catering manager. So there were ways how we would supply food to our COVID positive patients. So catering manager was involved. There was a dedicated lift which will go into that particular wards only, and it would not stop in any other flow. The more important was how to take back those utensils for use. So we were using only disposable at that point of moment, and they were disposed in a yellow bag. They were collected from the wards, and then they were sprayed with hypochlorite solution. So the catering manager was involved how to take care of the material which was coming out, especially the eating items from that room. CSSD manager was taken into account because anything which has to go through this area, it has to be properly sterilized and disinfected before use. Housekeeping manager, he was important because cleaning and disinfection protocols need to be placed. Then hospital chief pharmacist, we all remember a time when mucormycosis outbreak happened. Actually, there was no amphotericin B was involved. And even in COVID time, remdesivir was rationed actually. So he was an important part of hospital chief pharmacist. Supplies officers were important to for the resources. Representative of any other important were important. As the need arises, various people were taken into account, and this all formed a major outbreak control group for us. Then responsibility for continuing care of patient lies with the consultant under which the patient was admitted. So you cannot deny under the consultant who the patients were admitted. So patient care, what was required, need for active and passive immunization may be considered. So at that point, when the COVID positive patients were there, the immunization was not there. But other cases, active and passive immunization can be considered apart from COVID. So this is generalized term I've used here. Need for antibiotic prophylaxis needs to be considered. Like there was a protocol to be shared that when we have to start various antibiotics for our COVID patients. Protective isolation for susceptible individuals considered. So patients, healthcare workers, those who were coming and seeing those patients, protective isolation was important. Isolation facilities, adequate number of suits, rooms, isolation pods was considered. So what we did in our hospital was we had to create specially negative pressure rooms for triage area. And we have also created our wards which were negative pressure rooms. So adequate facility was ensured. Isolation policies were implemented. Additional facilities, if required, in the hospitals were considered. Policy on patient admission. So transfer and discharge were defined. So this was very important once the hospital started filling up with the patients who even did not require admission. So there was a policy for patient admission that a saturation less than 95% were only the people. Patient with comorbid conditions, they will be admitted, and on which day they will be transferred to a normal ward other than COVID ward, or a discharge may be planned. So these were again a part of patient care outbreak control group. Policy of movement of patient staff within and between hospitals were defined. So in case of COVID, we could not take these COVID patients if need to be transported for, say, radiological facilities, or for maybe a cath lab, a patient had a cardiac problem, he needs to be going to cath lab for further procedures. So the movement of these patients and staff was defined that they can use a particular lift only, which will be cleaned and disinfected later, and there will be a particular route only from where they can manage to go. And there was no mix of COVID patients and non-COVID patients. There were no mix of normal staff and a COVID dedicated staff. Visiting arrangements were defined, definitely expert advice implemented, and additional nursing and medical staff was considered during the interval of this patient. So these were the important things which were pertaining to patient care. When we talk about outbreak, the communication is the most important thing. More cannot be defined. For good communication, individuals or organizations who need to be informed about the nature and progress of the outbreak, then one member will accept responsibility. So in this case, a medical director, medical superintendent was responsible. And most of the cases, the microbiologists were doing it, but that was second in command when we had talked about our hospital setup. But you can have a consultant microbiologist who can give the communications. Then the important part for anything in management has there any additional staff. So higher management was taken into account that we were needing extra nursing staff, which could be arranged from non-COVID hospitals. Medical staff, it need arises, other like clerical, domestic. So a lot of data entry was required during that day. So a lot of clerical staff is also required. Then laundry arrangements need to be reconsidered. Then isolation facilities defined, the ward was considered, isolation nursing procedures need to be defined, the planned admissions were considered, and admission officers. So these were the coordinated activities we can say that management has to take into account, that who will define all this to get a major outbreak into control. And it should not become that COVID patient had come non-COVID and he became COVID positive in our system. So that was major concern. And the other concern was the adequate facilities were available for them, adequate procedures were available to them whenever the patient of COVID has entered. There was increased secretarial and communication facilities. So there were twice a day, we used to have this major outbreak control group meeting. How many patients are, say, positive patients were in the hospital setup, and how many patients were on ventilator, how many patients were not on ventilator but critically ill, and how many patients were in wards. So daily communication channels were there, and daily reporting of data was shared between the major outbreak control, and available of adequate supplies that specially need medicines were assessed. Special measures for staff protection and define antibiotic prophylaxis. So antibiotic prophylaxis in second and third wave was not required. So just to share an example, when first wave was about to hit India, there was a prophylaxis which was like chloroquine tablets were given for antibiotic prophylaxis. I think ultimately it came to be that it was not required, but during that time we had considered as a major outbreak control that antibiotics should be given for staff protection. Catering procedures were defined, as I told you, how to transport food out of that COVID area. Domestic and housekeeping procedures. So usually all waste materials, whichever was generated from COVID positive wards, it needs to go into yellow bag only, and that needs to be incinerated. So there was a COVID waste material designated area was defined, created, and all the waste would go into that particular area, was not mixed with non-COVID patients also. Nursing, medical, and paramedical staff was informed of every COVID patient who was admitted in the hospital. There was a system like infection control nurse would inform the nursing CNO about the latest update, and then that information will go down. Communication was done from the supervisors to the nursing level. Nursing, medical, and paramedical staff as well. And especially, this was important, special arrangements required on the death of infected patients defined. So ICMR made it mandatory that every death which was reported during that COVID time had to be COVID designated, either a COVID death or a non-COVID death. So RT-PCR samples were taken of those patients who had expired, and we defined as a COVID death or a non-COVID death. If it was a COVID death, it has directly went into for last rites in these respective areas wherever they were defined by patient's attendant. And there was a packing mechanism of those COVID related deaths also. So they were first disinfected, all holes needs to be completed, then they were covered in the transparent sheet, and then in a white sheet and a special bag before they were handed over to the patient's attendant. So there were special arrangements needed, and this all was done by usually our security staff for a management of outbreak. So investigations, what are the investigations that are required for it? Who will be responsible for coordinating epidemiological investigations? So this is usually the responsibility of microbiologists. And case definition of clinical and microbiology criteria, they were defined by microbiologists. If I talk about COVID, they were all defined by ICMR. But if we talk about any hospital-acquired infections, maybe if we talk about any MRSA outbreaks. So if usually what happens, how we define this case, Just to share example, one case of MRSA is usually reported in 2 or 3 days. But suddenly when we start finding that 2 or 3 MRSA has been isolated from various areas or maybe one critical care unit, then we have to define that this is an outbreak or not. So that is the case definition have to be made on clinical and microbiological criteria, whether this is an MRSA, which was susceptible to vancomycin or not happening. So that also needs to be defined. Food samples are usually examined if we are talking about Shigella, typhoid, salmonella outbreaks. So usually a food samples can be defined on those cases. Engineers may be involved if we are talking about COVID, like negative pressure rooms were created in those areas. So that can be taken into account. Then environmental samples taken, if we talk about any outbreak, say MRSA, on only those cases environmental samples are taken. So suppose a patient who had operated in our OT, and later on his discharge we found that MRSA has grown. So the chain would be like root cause analysis when we do for this MRSA patient would be like, who are the people, those who are taking care. His axillary and nasal swabs needs to be taken, and from OT, if persons, those who have operated on that patient, their axillary and nasal swabs to be taken. So in that case, only environmental swabs we say taken, or maybe sometimes if it is coming from ET, endotracheal intubation, we also take suction swabs. So only in those cases, environmental swabs are taken, not in routine measures we should be taken for trying to find out hospital-acquired infections. Then sample transported rapidly to reference laboratory. Reference laboratory, maybe sometimes we have to give some high-end tests. Then for genetic sequencing, say, or genomic sequencing, then we transport these samples to reference laboratory. Like we say in Omicron wave, most of the patients who were coming with COVID positive, they need to have genomic sequencing done. So we were sending these samples to the reference laboratory. Epidemiological studies in progress need further studies were considered. So all the demographic details were collected so that we could monitor the progress and further studies could be considered. Follow-up contacts of infected patients undertaken. So we've been informing all COVID positive patients. So there was a huge load on government itself that they were doing a lot of contact tracing. And we all remember during the first outbreaks, the homes were sealed, quarantine measures were strict, and every patient who was coming positive contact tracing was done for these infected patients. So this is what the investigation consists of when we are talking about outbreak in our setup, that contact tracing is important whenever we are going through. Further microbiological or serological screening of non-infective people might be considered for patients, relatives, for staff and other contacts, and a list can be made for number of patients, their name and locations can be done. So that can be done. One important aspect is the provision of adequate number of isolation rooms or cubicles when we are talking about control. They are insufficient, it may be inappropriate. It may be appropriate, to use the cohort nursing. Cohort nursing simply means that where the patients can be shared side by side, or a staff can be shared if no dedicated person is available during that. We can also, now we have considered the active or passive immunization, we call it immunization against COVID is being considered. Then antibiotic prophylaxis, no antibiotic prophylaxis, especially if COVID we talk about, only the protective policy is there, that is masks should be used and hand hygiene needs to be taken. Protective isolation for susceptible patients to be considered. So worldwide quarantine policy was used, and that was a protective isolation method for patients, for attendants who were coming in close contact of the COVID positive patients. And isolation policies needs to be implemented. Disinfection policies and domestic procedures will be defined. I know not further can emphasize that hypochlorite solution was used. The hand hygiene things were used. In domestic isolation also, there were Lysols, which was being used, that how you clean the patient area or the quarantine once the patient comes out of the quarantine. So disinfection policies were taken. Now, policy need to be defined for new admission, discharges, transfers to other wards. This I already explained. For the control process, what are the patients that can be admitted, and then they should be discharged or transferred to other wards in simple. So usually an RT-PCR result would define whether the patient has come negative. He would be shifted to other non-COVID ward once he became negative. Then policy or movement of patients and staff defined within the hospital and to the other hospitals. That is how we had dedicated COVID and non-COVID area. Are any special precautions regarding for prevention of infection of staff? Yes, the special precautions are now these days vaccination. And even in second and third wave, we have seen that vaccinated had less of infective stages, we can say. So prevention of spread of infection of staff is very, very important by vaccination methods. Then visiting arrangements defined. Yes, till now we don't allow COVID patients to be in contact with other non-COVID patients. So visiting hours were restricted in our hospital also, and must have been in other hospitals too. So this was about COVID arrangement, COVID-19. Just to be very, very brief, I have 3 or 4 slides. What we did: investigations, ICMR guidelines was taken, test initiation of details were taken, personal details, specimen information from referring agencies, A4 patient category. So there were categories defined. I don't want to go into details, but these were the categories which were taken into account. Medical information need to be shared. Clinical symptoms and signs, they were noted. So date of first symptoms, pre-existing any medical condition. Part B was very important because the emphasis was on comorbid condition in this case. So hypertension, diabetic patients, they were taken into, and any procedure which has to be done recently, they were taken into account, along with hospitalization details and referring to doctor details were taken. There was also biomedical waste management, which segregated COVID positive patients. Biomedical waste management, everything had to go in yellow, even cap, mask, and COVID suits, and red bin had gloves to go with it. Rational use of PP was important. In what we have done is in COVID area screening, COVID suit and N95, goggles and gloves were given. In non-COVID areas, suits were not given, but you could use N95, goggles and gloves. In non-clinical areas, 3-ply masks were enough. That means a cloth mask or a 3-ply mask, surgical mask was enough. Turning technique, I've already told. And these were the topic technique. The most important part, what we did was risk assessments for those who have patients, the healthcare staff which was coming in contact with COVID positive patients. So we defined that if the healthcare staff was at high risk, if he was not wearing a proper PPE, that means he was not wearing a COVID suit, gloves, mask whenever he had come in contact with COVID positive patients. And those patients, those healthcare staff which were labeled as high risk were quarantined for 14 days in first and second wave. In medium risk was that no aerosol procedures was performed, but the healthcare staff was without PPE. So that was at medium risk. And low risk we would define if the patient was on 3-ply mask and there was no procedure and patient was seen at a distance. No risk if a proper PPE was worn. So they were the no risk if the healthcare staff was wearing full PPE, low risk if only a 3-ply mask was being worn by the healthcare staff, medium risk, we call it, if without PPE and there was no aerosol procedure was performed, but he was wearing a mask, and high risk if some procedure was performed without any proper PPE. So this was how we had quarantine our healthcare staff and a risk assessment was taken. Then this was our quarantine policy, which changed to 10-day quarantine. Now the sampling of RT-PCR was not indicated. This usually was done in the first COVID wave. Home quarantine, was defined separate room with attached toilet, wear surgical mask, dedicated person assigned to interact, household beach for disinfection of surfaces away from vulnerable age group, and 14-day HQ was also for code. In last few days, this was removed from the policy. 1% hypochlorite solution. Now the contact time was changed in this case. It was to 30 minutes instead of 20 minutes. That was a change which was required. Then dead body management, I already told. COVID sampling was required, or holes and wounds need to be sealed. Then body wiped with 1% hypochlorite chloride solution, bag in body bag, and disinfect with body bag.